Good afternoon, and thank you for attending today's training taught by Dr. Ergen. Sorry, let me start over. Good afternoon, and thank you for joining us for the Understanding and Reducing Stigma for Fetal Alcohol Spectrum Disorder session number 5. My name is Char Morrison, and I'm the program admin for today's training. Before we get started, I'd like to go over a few general housekeeping rules. Number 1, no CE credits will be awarded for phone attendance. You may still listen and or attend the training. However, there is no exceptions for receiving CEs by phone. For full attendance, you will be awarded 3 credit hours for today's training. If you exit the session early, your credits will be prorated. In order to receive proper credit from your board's discipline, you had to have provided your license number when you registered. If you did not do so, please use the FASD mailbox that's included at the end for general questions and or to provide your license registration phone number or license number. After the session ends, again, you will receive a survey link by email. Hope you participate, and we appreciate your feedback as soon as possible. The survey will remain open for about 72 hours, and then after that, it will be closed, and we will not obtain any more feedback from that particular survey. Everyone should receive a participation certificate within 7 to 10 business days with your correct hours. Please make sure your license number and your hours of attendance is properly recorded and or annotated on your document. If that's not the case, again, send your general inquiries back to the MAHAS-FASD mailbox. And then finally, if you have any other questions pertaining to your certification, again, hit us at the FASD email address. And lastly, all participants will stay on mute. We ask that you enter all your questions during the presentation in the platform question box. And next up is FASD Program Manager, Karen Kimbrough.
Good afternoon, everyone. My name is Karen Kimbrough, and I am the Maternal Wellness Project Lead at the Department of Mental Health and Addiction Services. As Shar mentioned earlier, this is our 5th training in a series of 5. So we've completed our training agendas for state fiscal year 21. And we look forward to providing trainings next state fiscal year or activities for you to participate in. The objectives for this training will be participants will increase their knowledge of what FASD is and the impact it can have as an individual diagnosis. Participants will recognize that many factors that impact individuals with FASD and their families. These factors include, but are not limited to, disability, socioeconomic status, familial systems, and stressors, cultural and social factors. Number 3, participants will be able to identify ways that stigma affects individuals with FASD and learn about advocacy methods to decrease stigma. We welcome you to this training. Enjoy. And next, I'll turn it over to Tracy Jackson to introduce our keynote speaker.
Thank you, Karen. It is my pleasure to introduce Dr. Götze Ergen, an associate professor and a licensed clinical psychologist at the School of Professional Psychology at Wright State University. She has a master's degree in clinical psychology and an APA-approved doctoral degree in school psychology. She completed an APA-approved internship at the University of Minnesota Medical School and Children's Hospital. Her teaching interests are cognitive assessment, child assessment, and clinical neuropsychology. Clinical interests include infant and toddler assessment, pediatric neuropsychological assessment, psychoeducational assessment, school psychology, school consultation, treatment of externalizing and internalizing disorders of childhood, parent training, assessment, and treatment of developmental disabilities, autism spectrum disorder, fetal alcohol spectrum disorder, and prenatal drug and alcohol exposure. Dr. Ergun is an active member of the Ohio FASD Steering Committee and conducts trainings and workshops and presentations in Ohio regarding prevention, diagnosis, treatment, and advocacy of fetal alcohol spectrum disorders. She is a member of American Psychological Association, including Division 40, and National Association of School Psychologists. And now I will turn it over to our speaker, Dr. Ergun. Thank you.
Thank you very much, Tracy, for the very nice introduction. And thank you, Karen and Shar, for all the housekeeping and opening our webinar today. I'd like to welcome everyone to today's webinar, where I'll be talking about FASD and the stigma around FASD, which I think is a very, very important topic and a subject that doesn't get really discussed as often. So throughout I know we're not interactive, we're not face-to-face, but even though we cannot still interact because, you know, being a big group, I still wanted to put out some thoughts and some questions here and there that are about myths or facts, and I'll ask those along the way. So please play along if you choose, if you chose to do that, and you know, think for yourselves. And then when I talk about, you know, whether it was a myth or fact, then you can check what you thought about the, you know, the response, because a lot of the things that I'll talk about today could be around some of our stereotypes, prejudice, and some of our, you know, preconceived thoughts that we might have regarding FASD. And today's topic is all about debunking our myths and hopefully trying to replace, you know, all of those with some of the facts today. So thank you so much for coming in our last series of our training, while we'll be kind of wrapping up, you know, for this year. So I will be specifically talking about, you know, stigma and what are some of the variables that impact the presentation of FASD, our understanding of FASD, and so forth. But maybe for those of you who may not have attended the prior 4 trainings where I specifically in detail talked about what is FASD, what are the red flags, how is it diagnosed, and so forth, I just wanted to do a quick overview. So please note that this part is not going to be in much detail because I detailed a lot of that in my prior one. So if there are any holes in this, please know that we have a complete series that you can go back and review and watch, and there are, you know, handouts and slides that are associated with each of those trainings where you're able to get more specific information. But just to start out with an overview. So for those of you who are new in this area and who are just wanting to learn a little bit more about FASD, who just heard about this training, and maybe for some of you this is your first time, it may not be, but for those who might be the first time, fetal alcohol spectrum disorders is an umbrella term. It is not a diagnostic term. It is an umbrella term to describe the set of disorders, the diagnosis that are under this spectrum and umbrella. And what does FASD mean? FASD means that a child has been exposed prenatally to alcohol during pregnancy. It really doesn't tell us, when you interact with a child with FASD, it really doesn't tell us when they were exposed, how much they were exposed, or how long they were exposed to alcohol. But what we all know is that there was alcohol consumption, and that's the necessary factor for a diagnosis. If there is no documentation prenatal alcohol exposure, then we are not able to provide the diagnosis, because what we need to do is we need to connect that some of the impairments in the brain that we see are as a result of alcohol's disruption of some of the structure of the brain. Because otherwise, it is a neurodevelopmental disorder. And if there is no prenatal alcohol exposure, there is no FASD. On the other hand, for other neurodevelopmental disorders such as ADHD, autism, learning disabilities, and so forth, or language disorders, there is more genetic loading, and there are genetic factors that are heavily there. They couple together with environmental factors, and that's how we see the emergence of the other neurodevelopmental disorder. But for FASD, this is different. FASD is not genetic. It doesn't pass on from genes. So that's the part that I wanted to emphasize today. So when we are trying to determine the level of impairment that a child has as a result of exposure, some of the things that we look at is pattern and quantity of alcohol consumption. When we say pattern and quantity, some women will drink heavily throughout the whole pregnancy, and that's chronic. That's what we call chronic. Some women will drink until they figure out that they're pregnant, and that happens a lot. So that means they will drink during the first trimester, and then when they figure out that they're pregnant, then they will stop. And then there will be some women who drink during the pregnancy, but not throughout the whole pregnancy, but they will binge drink. So they will drink a lot during a certain period, and then they will stop, and then they will binge drink again. So among these different patterns, the most, of course, harmful one is, of course, the chronic one, if they drink throughout the whole pregnancy. But then another very harmful pattern is binge drinking. During binge drinking, what happens is that the baby, the unborn brain of the baby, gets exposed to alcohol to a large amount. And the baby's brain is not able to consume or is not able to break down alcohol just like an adult brain. So an adult brain is able to metabolize it, and then it kind of like passes, and it doesn't really stay there too much because it's a full-grown adult brain. It's developed already. And then it kind of comes down to the body, and then within, 24 or 48, how much the drinking was, it just leaves the body. But it doesn't happen this way for an unborn baby. The unborn baby's brain is not well developed yet, and therefore does not have that capacity to metabolize it. So therefore, it stays there. And when it stays there, and especially in bigger amounts during binge drinking, then it starts to infiltrate and pass the blood-brain barrier, and it starts getting into the actual structures of the brain that are newly developing. As a result of that, what we see is that those brain structures are impacted and damaged. And what we see is some of the cells in the brain that are just developing, they die. So the baby is born with less brain cells, which is a smaller brain volume. So the brain size and the head circumference, the head size is smaller. And then some of the structures, they have been impacted because there is not enough communication between each of these structures. So that's what happens in the brain. The stages of the fetus development is really important. That means that if a mother drinks during the first trimester, then that's when the facial features develop. That's when our face and it starts to develop, and then some of the the facial features. So then we see the facial features that are common to fetal alcohol syndrome if a mother drinks during the first trimester. If a mother drinks during the third trimester, this is when there is rapid brain development. That's when we advise our pregnant moms to take a lot of protein, because protein intake really helps with the brain development of the baby. So, but when alcohol comes in, it disrupts all of that process and that nutrition of the brain for it to develop. Therefore, we see a lot of difficulties with cognitive skills, memory skills, executive functioning skills, and so forth. So third trimester is also very detrimental. And then the stages of the fetus development. It really depends on when the brain or when the fetus was developing and how it intertwines with the timing of the intake. So all of these factors are things that we cannot know, because a mother will not really remember when exactly they drank. They might say, in the first trimester I drank, but I don't remember, it was every day, or it's very hard. It's retrospective data. So therefore, we know that alcohol is a teratogen, but we cannot say exactly at what stage and what it does day to day, because the mother cannot really remember afterwards how much they drank and when they exactly drank. Therefore, there is no safe amount of alcohol during pregnancy, and even that one glass, if it's a time when there was huge brain development on a specific structure of the brain, it can make a lot of impairments. So therefore, we really cannot say like it's safe to drink at this specific time and this amount. So there is really nothing that we have that's backed up by science. Therefore, the safest way is to abstain from alcohol, during pregnancy, if that's something that the mother is able to do. If the mother drinks during the whole pregnancy, then what we see is fetal alcohol syndrome, which is the more severe and more serious kind of like type among the FASD diagnosis, where they have facial features, growth issues, and all of the neurocognitive impairments. So what is the prevalence of FASD? I will ask this question to all of you, and I'd like you to kind of think about that. When we say prevalence, like how frequently do we see someone with FASD under that umbrella, whether it's the more severe form or the milder forms where we don't see the facial features? First of all, FASD has been deemed as a public health concern. There has been a lot of studies. I was reviewing some yesterday even, and I figured out, so I should probably in my next presentations update that. May et al. Is the researcher who does a lot on the prevalence of FASD, and they have done 2 new studies which are dated 2020, and they did it in one in the Southwest US and one in another Midwest city in US. And then what they found was that it was around 4.8 and 4.7 exactly. So it's not even, I put it here because there was a range from, 1 to 5 or 2 to 5%. Now we really know, like in US, it's around 4.6, 4.7, 4.8. So we could say, safely it's close to 5%. Well, if we think about autism, we hear it all the time. Everybody knows about autism. Professionals know it, psychiatrists know it. A lot of, clinicians are very knowledgeable. Schools are knowledgeable about it. However, autism prevalence is, 1 in 59 or 1 in 58. It's somewhere around that. So that makes it around 1.7%. So it's much less prevalent, but there is so much more awareness. But thanks to our audience, like all of you, we will try to increase, our knowledge about FASD, and then making all of the systems understand and know that this is a prevalent neurodevelopmental disorder that can be entirely prevented if there is no prenatal alcohol exposure. So how does prenatal exposure affect a child? As I mentioned before, prenatal and postnatal growth deficiencies. First of all, usually babies are born before term, which is before 37 weeks. And they can be also born with a smaller gestational size. So they can be maybe born 38 weeks, but they can be 5 pounds. So they are not up to their level because alcohol disrupts that ability for the baby to get all the good nutrients as the mother is being, eating and then feeding themselves. So they can be small for their age. They can have a preterm, delivery and labor. And they could be also measuring small when the mother has, prenatal visits. So those are all of the things that we will look for in their background or medical history or developmental history. And then after they're born, some of the things that we hear for children who are not maybe yet diagnosed, but you can all have your flags up, is failure to thrive. When a baby has failure to thrive, again, it doesn't mean that all failure to thrive babies will have FASD, but a lot of them do have failure to thrive issues when they are babies and when they're infants. So they have hard time latching, they have sensory difficulties, oral motor difficulties to latching onto breast or to the bottle. And then they have difficulties with self-regulation, with sleep and feeding and eating and all of those difficulties. So all in all, when they are born and afterwards, when they get their measurements done, height and weight, they're always under the percentile that's appropriate for their age. So we will see some weight and height issues, and then their head circumference, which I mentioned, the brain size, the volume decreases. So their head circumference will also is going to be down. Another area that we see that's as a result of prenatal alcohol exposure is postnatal facial anomalies. And I'll be talking about what those look like in a second. And then we could also see disruption of alcohol disrupting how the body organs develop. And that's usually during between the first and after that second trimester. So we could see some cardiac heart problems, a lot of visual problems, auditory issues, and renal issues or some skeletal issues in the children as they start developing postnatally. And then the last piece is that we, due to the impact of the brain development, especially on the third trimester, then we see a lot of what we call neurocognitive issues. Neurocognitive issues are problems with memory, problems with using their hands like motor skills, problems with putting things together like visual spatial skills, problems with planning and organization, executive functioning skills, and problems with learning. They have a hard time learning big chunks of information. And they also have behavioral issues, such as they're usually very dysregulated. They have impulsivity. 70% of them also have ADHD and hyperactivity. And then they tend to have temper tantrums, meltdowns, mood swings, a lot of emotional and then behavioral regulation issues. And then the third area is adaptive deficits. We see a lot of difficulties with regulating self from the get-go, learning how to dress, feed themselves, be independent on their own, brushing their teeth. So they need a lot of instruction that's very explicit, and they need a lot of hands-on help and a lot of supervision to carry out day-to-day activities of daily living. So I know I mentioned some of the facial features. So as you can see in this slide, what we see is a smaller head circumference, okay? And then what we see is lower nasal bridge. And it means that really you won't see this type of, like what I have here, a little bit of a bump here. So you won't see that it's going to be very smooth. And then we see these epicanthal folds. They are the almost like a fold in the crease of the eyes, and there are smaller eyes, and these eye openings are pretty small. There is a pretty short nose, a very flat midface. So alcohol disrupts with the midline of the brain. So anything that develops in the middle of the brain, including the middle of the face, is smoothed out. Okay. So there is a short nose, flat midface, no cheekbones, and then they usually have that thin upper lip, very thin upper lip, underdeveloped jaw, and the philtrum. So the philtrum is the area between, if you all touch your ear for yourself and look at the area between the nose and the lip, if you do this, you could see there is a little bit of a bump going up here. So for our children who have the FAS and who have the facial features, will have a very smooth philtrum. So because alcohol, as I said, smooths out the middle of the face and that area. So something to mention that I think it's important to note is that not all children will have the facial features. If the mother has not drunk during the first trimester, but then started drinking afterwards, they could have all of the cognitive and behavioral and adaptive issues that I talked about, but they will not have the facial features. Well, where does this lead us? And how is this also related to our topic today? It's very related, because if a child does not have these typical facial features, then a lot of people think like, oh, they don't have FASD. Well, they don't have FAS. That's the severe form with all the facial features and all the issues. They might not have FAS, but they might have another diagnosis under the FASD umbrella term. So they could have all the other areas where they struggle still. But usually FASD is called what we call invisible disability, because when we look at a child and there are no facial features that we can identify, their IQ can be normal and average range. They can talk. It's not like autism where they have, some of the children have difficulties with language development, right? They don't have these stereotypical movements that we can identify, oh yeah, that child has this. So when you look from outside, in the absence of these symptoms, we would see a child who is conversing, who's social, wants to make friends, wants to be with family and others, and they don't have any facial features. We see nothing from outside, but they still have significant behavioral, adaptive, and other types of cognitive issues other than a general low IQ. So hope that makes sense, because I think that is a very important piece that perpetuates the stigma that's around, FASD. So how does disability impact our general outcomes and then stigma in the FASD community? Well, first of all, we have our primary conditions and disabilities. So these are impairments due to the underlying mechanisms in the central nervous system that result as a result of the prenatal exposure. And some of them that I already mentioned. So when a child has one of the diagnoses under the FASD umbrella, they will probably have problems with learning and memory. They learn, but in smaller chunks. And then it takes them many repetitions to remember and put it back in their memory. So, and the reason is that the area that consolidates information, which is that collects the information and then puts them into a memory form, that area gets impacted with alcohol. It specifically targets, because it's actually, unfortunately, it's in the middle of the brain, and as we know, alcohol disrupts the mid part of the brain. So therefore, it's like, I'm sure everyone has experienced that. You know, we all have computers, and especially these days, we're using more and more of them. And then let's say you have a corrupted file, and you're trying to save it to your tab file that you want it to go. You keep saving, and then you open it back up again. You can't open, and you can't read what you write, what you just worked on, and you just get all frustrated. And then you try it again, and then you just give up. It's the same for a brain, for the memory for a child with FASD. They learn, they want to remember it, but when they put it into the system almost swallows it, and it just does not give it back. But like today, if I asked you at the end of the presentation, what is the prevalence rate of FASD? You'll all be able to say like it's somewhere between 2 to 5, but the latest research in 2020 said it was around 4.7%. At least something, will stick in our memory, right? You will collect some of that information even after a short time today, after 2 to 3 hours. But that doesn't happen readily for our children with FASD. So then we will see avid problems in memory and recalling information. So these are some of the primary conditions and disabilities, but it doesn't stop there for FASD, okay? And this is the area that's really important, because if the primary ones, we may not be able to prevent. So if the mother drinks, there is not a whole lot we can do, then we work with the child who has FASD afterwards. But here, this is where our role as professionals supporting our families with FASD comes in. Once they have their primary symptoms, we have the ability to make sure that they do not develop the secondary disabilities, okay? Because FASD is a lifelong neurodevelopmental disorder. They will already be dealing with the primary symptoms. We don't want to add the secondary symptoms, and we can do that. So the individual with FASD is not born with the secondary disabilities. These just get added because of their primary issues and because of the stigma that they experience, and because all of us, in different formats, we lack the information and the awareness about FASD. And therefore, we do not provide these families and these children the right interventions, the right diagnosis, the right educational opportunities that they deserve. And at the end, what happens is that a lot of them drop out. The more they drop out, the more they are in the legal system or other systems, right? We want to keep them in school. The more they develop mental health issues, 70% of them develop mental health issues. That's a significant number. It's almost 70 to 80%. So that meaning that we can have a child, they are not supposed to have anxiety or depression, but with all the things that they experience in life, going from home to another home, being separated from their birth families, which sometimes may or may not be avoided, but we can avoid that they don't change 5 homes. We want to make sure that we understand what FASD is. We find a home that will be their forever home, hopefully. And so they don't develop these mental health concerns. Again, 70 to 75% of them end up in the legal system. This is a huge number compared to other neurodevelopmental disabilities. We would like to prevent that. We would like to teach them appropriate social skills. We would like to teach them appropriate safety skills and sexual behaviors, because a lot of them do end up having inappropriate sexual conduct issues that make them, end up in the legal system, or they get into trouble with the law because they go along with their peers who suggest that they get into trouble, but our kids with or teens with FASD don't really recognize, if I do this, I will get into trouble. Another child with behavioral problems, actually they know it, but they actually go ahead and do it. But our children with FASD, they really cannot connect the cause and effect, the behavior and the consequence. So therefore, from early on, once they're identified, we really need to focus on teaching these skills so that they don't end up in the legal system. They also have more involvement in substance use disorders. This is nothing genetic. There is nothing genetic about FASD. It's because they were born into maybe drugs and alcohol. The home environment that a lot of them were initially raised in had exposure. So they were kind of born into that kind of environment. So that kind of makes them more vulnerable to be exposed to those and therefore have access to it. And they also have 70% of them have ADHD, and ADHD, they're impulsive. And impulsivity definitely paves the way for making those impulsive decisions of, oh, maybe I can go ahead and try this. No, nothing will happen. Again, cause and effect relationship is not firm because it's in the frontal lobe of the area. That's where it's developed. And alcohol also targets that area. And as I mentioned, inappropriate sexual behaviors. So if we teach safe touch, safe sexual behaviors, what is public sexual behavior, what is private sexual behavior? If we teach these skills early on, then we can definitely prevent some of the occurrence of these secondary disabilities. So I really wanted to emphasize this because they're already dealing with huge and very heavy primary disabilities and primary impairments. While they're dealing with that, I think the system owes, and really we're supposed to kind of really protect them and put those protective factors in place so that they don't get impacted with these or bombarded with these secondary disabilities, which puts them in more dire conditions. So a little bit more on the specific areas affected for, again, those of you who have not maybe, listened to the other trainings. The neurocognitive challenges that I talked about is that they could have lower IQ, but I wanted to put it out there. Some children will have intellectual disability. Then it's easier in that sense to identify it because then they would say they have ID, these are the services. But on the other hand, most of them will have what we call borderline intellectual functioning. Borderline is, it's not as severe as having an intellectual disability, but it's not average either. So that means they will always kind of struggle with school and they will always have learning difficulties, but not that to the level of having an intellectual disability. But on the other hand, some children with FASD will have average IQ. They will not have any problems with cognitive functioning. Okay, so that's why, as I said at the very beginning, if you are interacting with a child, let's say in a school, and you say like, this child is brilliant, they are smart, why do they behave like this? Why can't they understand that if they do this to a peer, the peer will lash out? Why do they keep tapping all the time? And I told them 100 times not to do it. So that's when everybody gets frustrated, right? So those are some of the ways that we can kind of identify. They also have executive functioning difficulties, which is difficulties with planning, organization, transitioning, problem solving, and engaging in abstract thinking. So anything abstract like math, learning time, learning to deal with money, those are extremely difficult tasks for children with FASD. And therefore, as a result of that, a lot of them develop math learning difficulties. As I mentioned before, they have a lot of memory challenges and problems with visual spatial. Visual spatial meaning that you see something and you try to do it. Just like you buy something from IKEA. I don't know who is there with me, but I probably have some visual spatial difficulties as well. I cannot put things together very easily. But what I'm talking about, of course, here is not being able to put together blocks or puzzles or anything they need to do with their hands, or like figuring out reading maps, directions, and all of those pieces. But to the extent that it's more considered a deficit. I mean, of course, all of us are on a continuum on all of these skills. Other areas, self-regulation. So children, when they're born with FASD, their system of self-regulation is definitely impaired or damaged or impacted. So they're born with their system already dysregulated. So therefore, we evidence and see a lot of mood in behavioral and emotional dysregulation, which is very, very significant and probably one of the most important areas in FASD. And they also are very impulsive, hyperactive, and they have inattention or attentional deficits. So of course, all of this section will have a lot of implications in the school, right? The teacher will say they can't settle down, they get upset too easily, they get frustrated very easily. Other kids can aggravate them very fast. They can't pay attention. They just touch, peers' belongings, and they have hard time staying on task. So those are all the things that we will hear from teachers being frustrated and not knowing what to do and tell the parents to go get a medication for their ADHD. Well, not knowing that they also have FASD probably. And then last is adaptive challenges. Adaptive challenges are, they probably have, some of them are difficulties with communication. Communication, I don't necessarily mean like not all children have language delays. Some children who have the more severe form, like the FAS that I mentioned with the facial features, growth issues, they will also probably have language delays and language deficits. But again, a lot of the others will learn to speak and will communicate with you. They will talk typically, and you wouldn't understand that they have FASD. But when you listen a little bit more closely, they have a hard time with understanding the gist of things. They will have hard time understanding things that are a little more abstract. So they think and speak more concretely. Okay, so anything that's a little bit beyond that concrete level, it might fly off. So you might need to repeat. You might need to explain more specifically. So when you see that, you explain more specifically in more concrete terms and in smaller chunks, they don't have a problem of that communication. But not everyone knows that, and therefore they just go on and on and on, and they expect them to take in all of that information. They could also have fine motor and gross motor skills. They could be clumsy, engage in lots of accidents, and be very accident prone. And you might not understand why they keep falling all the time, why they have hard time opening jars, opening doors, buttoning, zipping, and all of those basic adaptive skills that will help them with addressing and navigating within the home environment. And finally, social issues. Our kids with FASD are very social. They want to be with friends and they want to be with family. They're artistic and lots and lots of strengths there. But when they try to do that, they have difficulties due to their impulsivity and sometimes aggressive behaviors. And they have difficulty with physical boundaries and limits and not knowing who is a friend and who is a stranger. So they might go up to someone and tell everything about themselves. So that's why I mentioned about teaching social skills, safety skills, and safe touch. They might also be in position where they might be taken advantage of or be abused due to these social naivety or social gullibility that I was talking about. So hopefully I was able to convey some of the effects of prenatal alcohol exposure. And I think the last piece before I wrap up this section is diagnosis. So because you might wonder, how do we go ahead now that we talked about some of the symptoms and why FASD occurs and how prevalent it is, how do we go ahead and diagnose? Diagnosis of FASD requires an interdisciplinary team. First of all, starting with the facial features. Genetics or geneticist or a developmental pediatrician who is knowledgeable in FASD facial measurement need to do facial measurements, okay? And then they can say, no, we don't have the facial piece. Okay, so then we can be good. We'll move on to the next area, which is height, weight, and head circumference below the 10th percentile. Geneticists can measure that, or a pediatrician can do that, and we get that information. They may or may not have it. Some may have had it in the past and they're better now. Some still continue to have difficulties with growing because, again, as I said, alcohol stunts that, that growth prenatally. And then the third one is all the neurocognitive areas that I talked about. Those can only be, there is no MRI or there is no neuroimaging to just kind of like say what those skills are. They need to be assessed and evaluated through testing and assessment by a clinical psychologist or a clinical neuropsychologist to evidence whether they're average, whether they're below average, and which of those areas are within the below average range through various tests and rating scales. So all of these players, they all need to work together, whether they're in a one clinic like an FASD clinic, like we have in Ohio, in different places like the Double Arc, or we have, FASD clinics in Cleveland, in Nationwide, and so forth. So there are some FASD clinics, but other than that, there are also some different places throughout Ohio and other places in the country, individuals who do FASD evaluation. So if you need to get your child evaluated and you have suspicions that they might have FASD, as you call a certain organization to inquire for it, please always ask, like, is there anyone who does evaluations, diagnostic evaluations for FASD? Okay, and then always try to go to genetics first, get the facial measurements and the growth issues figured out, get your report, and then go to the psychologist or neuropsychologist to get all the other parts measured and then evaluated. Then the psychologist can put all that information together for you and arrive to a diagnosis. Under DSM-5, we diagnose as other specified neurodevelopmental disorder due to prenatal alcohol exposure. And then we can specify whether that's a full-blown FAS, whether that's a partial FAS, like where they don't have all the facial features, but some of it, or it's alcohol-related neurodevelopmental disabilities, meaning that they don't have the facial features, they don't have the growth issues, which is great, but there was some impact on the brain in the areas that I already talked about. So a child can have one of these diagnoses under the FASD umbrella, okay? And that's how we arrive to a diagnosis. All right, I think this is now a good time because I'll be transitioning to specifically talk about what is stigma and FASD and how does that play out. So I think it's a good time to take some questions about the introductory part.
Hi, Dr. Ergen. There are no questions at this time for the introductory. So maybe everybody's been watching all along or looked at them on our website.
Yes, so I will, if that's the case, and if you're already knowledgeable, and this was just like hopefully a quick summary and more ingraining some of these facts and so forth. So that's definitely wonderful. But for those of you, who are just learning, we welcome you all too, and then applaud you for being here, for wanting to learn more. Although I see one kind of blink about a question, or that's not the case.
Let me check that blink. I see JJ just wrote like some simple comments. He said he's got one. So let me check that blinking light.
Okay.
That's from one of our organizers. So go ahead.
Okay, alrighty. Thank you. And I'll get more questions along the way. So if you think about any other, yeah.
Dr. He said, did I hear correctly, Nationwide Children's has a diagnostic team?
So I'm kind of like, looking a little bit more into that, but they do have more of for NAS, which is neonatal abstinence syndrome. So that I think the focus is more on that, but usually prenatal alcohol and drug exposure go hand in hand. So as they are doing the evaluations for NAS, I think they need to rule out FASD. So although it's not as targeted as the Double Arc, which is only solely around FASD diagnostic evaluations, they also do look at that, and they need to kind of like tease it out to see whether that's FASD or not. And all the people out there that are the doctors and are knowledgeable in the generally around prenatal alcohol and drug exposure. Also, they can work with the genetics department to pass back and forth, and there are also a lot of neuropsychologists there. So it's definitely worth kind of exploring. And then, as I said, usually alcohol and drug exposure, they go hand in hand, and they're not like in silo, like one mom just did drugs or just did alcohol. They're usually kind of like together. it's not as like specifically established like in many of the other parts of the country, like in Minnesota, there's in other places in Washington, DC, not DC, but Washington and Seattle, there's like all these just FASD clinics. It's not like that. It's kind of combined with the NAS part, and NAS being more at the forefront.
Okay, Dr. Ergen, there are a couple more questions. Is there another type of exposure that causes similar symptoms in a child? I have worked with families that say there was not exposure to alcohol, but all the symptoms seem to be present.
Okay, that's a great question. I think this is one of the circumstances where we cannot evidence or provide evidence for the prenatal alcohol exposure. Currently, this type of presentation is specifically to alcohol. We know exactly where alcohol targets in the brain, and it targets the memory system. It targets the planning and organization system. It targets our ability to, our motor skills. Think about someone who is intoxicated. They don't have FASD. Any one of us, who has had consumed alcohol at one point, what happens? We don't remember things well. We can't pay attention. So we have temporarily memory issues, temporarily have attention issues. It's hard to walk and balance, right? We kind of get clumsy and so forth, coordination issues. And then if somebody's telling us something, we have a hard time integrating and generalizing. So we probably need to talk to them later when the alcohol has left the system. It's the same. We know exactly how alcohol targets the brain. So this presentation cannot really be exactly the same as another, presentation. So probably in that case that, our audience has mentioned, probably there is alcohol exposure, but it cannot be evidence because the records are not there. It's not being, maybe shared and so forth. So it's very hard to get a presentation like this that kind of resembles exactly this profile.
Okay.
Although the one thing I wanted to add there are a couple, and I don't want to go into that specifically, genetic conditions that might resemble this. So I still want to say that. So I think the best bet for that family is to go through genetics, have that genetics work up done, because there are one or two that are quite similar. Okay, so that might be the only case that I would say that that's how they might overlap specifically. So I would suggest going through genetics and then having a genetic evaluation done.
Okay. The next question, we've seemed to got a couple more questions. You mentioned that FAS and drug exposure go hand in hand. Will other drugs cause the same facial features?
That's a great question. Other drugs, such as, cocaine and, heroin or methamphetamine or, opioids and things like that, they do not cause the facial features. So alcohol is the only specific teratogen that kind of like targets this midline of the brain that I mentioned, which causes the facial features. Okay, so then you could say like, what does then the drug exposure do? So if we have to order them in that order, alcohol is the worst and the most detrimental teratogen. Okay, then the drugs, and among those, we see a lot worse impact for the cocaine, and then kind of like the others lining up. And then tobacco or cigarette smoking during, pregnancy. So drugs and both cigarettes, they do also have a lot of, impact and implications, but drugs, they do cause all of the initial withdrawal impact. They cause neonatal abstinence syndrome in the baby. The one good thing is that it can be detected at birth, unlike FASD, right? And then drug exposure causes or leads to, we can't say causes, but leads to or is associated with learning difficulties, severe ADHD, inattention, hyperactivity, impulsivity, and behavioral dysregulation. However, we do not see the facial features with drugs.
Okay, and lastly, can a child develop some of this damage from the father's drinking?
Yes, we get that question quite a lot, and it's a very valid question. So when the father drinks, it must be then, before pregnancy, right? Because this is only impactful to the unborn baby, which is carried by the mom. So if the mom doesn't drink during pregnancy, then we will not see FASD. However, let's say if the father drank before conception, okay, that alcohol does not pass through the sperm to the unborn baby yet, okay? But then what happens is that if the father has used alcohol like a lot before conception, it impacts the motility of the sperm and therefore leads to infertility in the couple, okay? So, and then if the father has substance use issues, and then a baby is born from that father, genetically, there is genetic passing of being inclined to have substance use issues. So that's more of a genetic piece, nothing passing through the sperm that's going to be impacting all of these symptoms and so forth. So if the father drinks before conception, it only impacts their fertility issues. So they might not be able to conceive. That's more of the issue. But if the mother doesn't drink during pregnancy, we don't have FASD.
And that's it for the questions right now, Dr.
Thank you. Yeah. These are wonderful questions. Thank you for all our audience for raising them up. So the next area that I'd like to talk about is stigma and FASD, which is the bulk of our, or the focus of our presentation today. So first of all, I'd like to kind of like start out with talking about what is stigma. Stigma is a socially and culturally constituted concept, right? Where a person is identified as being different. But this person is different for certain reasons. And then they get devalued, and then this leads to a status loss, a loss in their status as a person, as a being, and then also leads to discrimination, okay? So when we think about stigmatization, then a couple of things kind of like come to my mind, and these are, I'd like to talk about a little bit of these. The first thing is stereotypes. So again, if we were live, then I would kind of ask like, what is a stereotype? A stereotype is an overgeneralization about a group. An example would be people with mental illnesses are dangerous. If you think that way, if somebody thinks this way, this is a stereotype about a group, and the group is people who have mental illnesses. Okay? Then these stereotypes lead to prejudices. Prejudice is agreement with those stereotypes and beliefs that leads to an emotional reaction. Okay? So if you think that people with mental illnesses are dangerous, then your emotional reaction is, oh, Jim is mentally ill and I'm scared of him because I'm scared what he might do to me or, my children and so forth. So this is a prejudice. This is an emotional reaction. And then this leads to what we call discrimination. Discrimination is when unfair behavior is directed towards a specific group or an individual, okay? So discrimination now is the behavior, right? So for example, if Jim is mental illness and if the neighbor, Maggie, has that stereotype and she's scared of him, then she will avoid to talk to him. And he would wave, maybe he's in treatment and so forth, and maybe she'll just wave and then turn around and not want to interact with him because of that. So that's going to be avoidance, and that is discrimination. Okay, so all of these kind of like practices, when we put them all together, is called stigma. So when it relates to FASD, Rosen has done a really recent study to investigate the different types of FASD-related stigma that individuals with FASD and those caring for them experience. Okay, so I'd like to talk about this, and I thought this was a nice graph to kind of depict all of the different types of stigma. So everything kind of like starts out with that public stigma. That's why it's kind of like in the middle of all of this. Okay, so I'll talk in detail about public stigma, but I just wanted to tell how these perpetuate one another. So public stigma is when everyone else in the public, what they think about you, and then the stigma that they hold towards the individual with FASD or towards their caregivers. So once you experience this public stigma from professionals, caregivers, to school, to medical doctors and so forth, and then you start to develop this self-stigma. Self-stigma is kind of like believing that, yeah, maybe I'm not smart enough. Yeah, I have brain damage and that's what everybody keeps telling me. Maybe I can't do this. That's why I can't do this. Yeah, yeah. And then they start to kind of believe in these, the stigma and all of these, prejudices and stereotypes. And after that, the stigma by association is for those who are next to the person with FASD. Those would be foster parents, adoptive parents, and birth parents, or for those who are caring for individuals with FASD. So you get the stigma as the parent because your child has FASD. So that's called stigma by association, okay? And then you start feeling, well, maybe then I'm a failure. I can't handle my child's behavior in public anymore. I don't know what to do. I don't know how to get this diagnosis. I guess I'm not a great parent. So it starts to perpetuate the self-stigma again. And then the structural stigma is what we, and I say we because I think everyone is in this together. And that's why we're talking about this today, to bring it to the surface and say maybe what we maybe all contribute to the stigma and how we do that and how can we prevent it. Structural stigma is the stigma held by the structure, the system, the organization, which could be government, media, providers, clinicians, schools. So all of the organizations and system that a child with FASD is and lives in, will have some type of stigma towards these individuals with FASD. And those also will impact the self-stigma all in all. So hopefully as it kind of makes sense as to how each of these kind of perpetuate one another. And then it becomes this vicious cycle where all of those primary symptoms that I talked about today will even get worse and then lead to the secondary disabilities and the symptoms that I already talked about. And that's why I mentioned that if we can reduce the stigma, if we can break anywhere in this graph as far as making the stigma worse, then we are doing a service to our families and children with FASD for making them believe in themselves, not feeling like failures, and not feeling that the system also failed them. But unfortunately, a lot of them don't feel that way, and a lot of them feel that the system and everyone else has failed them, and then they don't really know what to do. So now I'd like to kind of talk about each of those, but I wanted to kind of, just to break it up, put a myth or a fact game in there. So I'll read this statement and I'll talk about this research in my next slide. So I'd like you to think and maybe have an answer in your head, and then we can check back again to see if this was a myth or fact. So, is this a myth or fact? Mothers of children with FASD do not experience greater stigma or stress compared to mothers of children with other mental illnesses like schizophrenia, like depression, or substance use disorder. So let's think if they do experience similar ones, or more or less. So which one it is? So let's think, and then I'll talk about the research around that. All right, so first of all, I'd like to start out with talking about public stigma, okay? Because that's kind of like the first, the first big piece. So public stigma is that represents people's cognitive, affective, and behavioral reactions to a person that they perceive to have a stigmatized condition. And in our case, the stigmatized condition is FASD, okay? So overall, National Academy of Sciences also kind of like, put together the kind of like the fact that the public stigma is very detrimental to individuals. And then the parents also get blamed for their adult child's, mental illnesses or mental conditions. So Fleming did a study, and in their study, they looked at some of the responses to an online survey. And then the online survey was about individuals. It was depicting a personal story of FASD. And then some of the things that they kind of like had were kind of like looking at how the people shared their thoughts about this personal story. And then what they found was that the 42% of these comments were negative. Okay. And some of these comments were like this, and I will read a lot of these comments throughout this presentation, and I know it can be pretty upsetting maybe for some of us. So I just wanted to put it out there. I'm sharing these only as they were indicated in the research, and of course, only reflecting the respondents' thoughts, and only to highlight, not to upset you, but just to highlight all the stigma that's out there. It's hard to hear. Some of the things I'll say are really hard to hear, but I think we should start these hard and difficult conversations as to what our families are going through. Okay. So from that study, some of the things that they say were that women who are unable to stay clean during pregnancy should not be allowed to have children. And then that these mothers are bad. This often happens due to poverty. And then there are many severe hurdles to recovery, and therefore, if they have not recovered, that they should not really, have children. Of course, all of these are very negative and very blaming and very guilt-driven towards the biological mothers who were probably in a condition of having a substance use disorder that was not being treated, or they couldn't be reached to be treated. And as a result of that, that's what happened. Okay, so a lot of these messages were very, very negative. And then to answer our myth and fact question, they did a really, really nice study. So I'll explain that a little bit. In this study, they compared the public stigma of mothers of children with FASD, with mental illness, with substance use disorder, and then mothers of children with jail experience. Okay, so, and then they gave like fake dollars, like fake money, funds to each of these participants. And then they said that if you had to donate money or give money to a cause, where would you allocate your money, to which type of mothers who have these children with different conditions? Okay, so what they found was that the mothers of children with FASD got the least amount of dollars from the participants. So what that means is that the mothers of children with FASD were viewed with more blame, more disdain than mothers of children who had mental illnesses or substance use disorders. Okay, so it was the least and then the lowest compared to all of the other programs. And some of the myths that people have talked about in that research was that, well, FASD services apply to few people. It's not, I mean, it's only those few who had drunk and then their children have it. So it's very rare disorder. Well, I've just discussed at the very beginning of this presentation, we're talking about almost 5% of the population. So this is nothing rare. And then what they also said was that they have brain damage as a result of alcohol exposure. There is nothing called that can be done. So we would rather have the funds allocated to another group where we could have an impact. Well, but what we know is that all the other groups we're talking about, like depression or autism and all the others, there is genetic passing, and there is already an impact on the brain too. So how is that specifically different than two of those impairments that are already there? So they are equally effective in terms of equally helpful to make the lives of our children with FASD more meaningful, as well as their families. Okay, so what they also saw was that they tried to see if having a personal experience within these groups helped out to give them more funds. Okay, and then what they found was that when the participants had some kind of personal experience, like a family member who had a teen with drug issues, a family member who had a teen who had bipolar, okay, when they knew someone who was going through this issue, they felt more connected. They felt more open to having these conversations, and therefore less stigma, and therefore they provided more funds. So this comes back to familiarity, and then having that more personal experience and knowledge about a certain disorder, which makes people having less stigma, less public stigma, and then engaging in more prevention or more intervention efforts towards this group. So I thought that that was a really significant research to kind of like highlight the public, stigma that the mothers were kind of, really experiencing. So let's see. So the next thing that I'd like to talk about is who can experience the public stigma. Okay. So, and then what kind of stigma, is that? Well, regarding the public stigma, first of all, the biggest one that we see is towards biological mothers who consume or consumed alcohol during pregnancy. So there was a research by Corrigan in 2019, and then they looked at what kind of themes are we seeing. So they did a focus group, and then they asked questions to participants as to how do they view biological mothers who consume or consumed alcohol during pregnancy. And again, some of these responses are pretty upsetting, but again, I will share those with you to highlight what those are. So the biological mothers were construed as bad parents, neglectful, child abusers, addicts, in denial about their substance use or dependence issues, that they were responsible for the negative health outcomes for their children, that they were ignorant about, not knowing about the impact of alcohol during pregnancy, that they lacked self-control, they voluntarily consumed alcohol. A lot of, stereotypes and assumptions, right? That they were blamed and shamed. Some of them even said they deserve harsh punishment. And then they asked the question, how could they do it? They assumed that these mothers had poor social connections, low SES, and a history of maltreatment or abuse, for themselves. And then they had poor prognosis for recovery, and then nothing, could be done for these parents. So as you can see, this is very upsetting, and lots and lots and lots of stigma towards biological mothers who consume or consumed alcohol during pregnancy. Another target for the public stigma for FASD is non-biological parents of children with FASD. Who are they? They are the foster parents or the adoptive parents. So usually what research that was done again by Corrigan in 2017 and Bell by 2016 show that the foster and the adoptive parents get blamed when a child shows difficult behaviors in public. So it's almost like, how on earth you can't have a control of your child, and why is this child so, aggressive, and what's going on? So the parents, the adoptive or the foster parents, kind of like start feeling that maybe I can't do this, maybe I'm not cut out for this. Everybody is looking at me, and I just don't know how to control my child. I don't know what to do. They start kind of like feeling really guilty, and they kind of consider themselves to be a bad parent. And what research shows is that a lot of them kind of like find themselves in a position to have to explain that this is not their biological child, which is very hurtful for an adoptive parent to kind of like needing to say that. If they want to say that, of course they will say it. But if they don't want to say that, they shouldn't be in a position, they shouldn't be forced to say, well, I'm not the one, who drank, this is my, adoptive child. They shouldn't really be in a position to say that. But what research shows is that a lot of the times the non-biological parents get blamed for their children's, specific difficult behaviors. And then the last one is the target for public stigma is of course, to individuals who are actually living with FASD. So what were some of those themes that was found out in the literature? Some of the things, again, are very, very harsh and very difficult to hear. As I was reviewing the literature, that just broke my heart several times, and I had to have a moment with myself to kind of like see, what can we really do to prevent this type of, guilt and blame. So they were, individuals with FASD were regarded as different than, typical children. They were indicated as having a brain disorder, having a really bad prognosis, that really we can do anything much for these children, that they drained the society due to their medical and social needs. They were stereotyped as immature, lazy, or violent. A lot of people thought that all of the kids who were exposed have facial features, which we know is a myth, right? They were considered as problematic by their teachers. They were thought to have low self-esteem, low self-confidence, social isolation. They were regarded as social failures and who will engage in criminal behaviors later on. And then they felt very misunderstood, underestimated as a result of all of these horrible stereotypes, disrespected, bullied, and blamed for their own challenges. So what this shows us is that a lot of people think that the misbehaviors or the difficult behaviors that children or teens with FASD have are willful, that they actually have a control over their behaviors. And it's more attributed to the person than to the disability or their difficulties. So that's where, again, we can come in, because if we can provide the correct diagnosis early on in an appropriate time, then we can prevent all of these stereotypes and have everyone view these as, well, just like autism, an autistic child will have difficulties with social issues, and a child with FASD will have difficulties with self-regulation. It's as clear as that, right? How can we accept that for autism, but we cannot accept it for FASD? So that is definitely an issue. So I would invite all of you to start kind of like thinking of this and how we can spread the word and how we can prevent the perpetuation of all of this type of stigma. Another piece that I'd like to kind of go back is now self-stigma, because I don't think I have a separate slide for that, but I'd like to talk a little bit on that piece. So we have reviewed what public stigma is, and then how it impacts the parents, the adopted parents, and the individuals with FASD. So that's very clear that it's a very negative piece out there. What about self-stigma? So self-stigma is the social and psychological impact of having a stigma. It's almost that anticipation of being stigmatized. And then the more you hear about it. It's just like, let's say a person is, heavy, and they keep all the time hearing that they're heavy, they don't look good, they don't belong, and things themselves, and then they start having second thoughts about how they appear. Maybe they didn't think about any of that before. They start developing these, thoughts. It's the same for individuals with FASD. They now internalize all of these negative beliefs and feelings, and then they start engaging in self-blame and self-shame. Now they're ashamed of because they have a brain that has been exposed. So research shows that biological mothers who have children with FASD engage in a lot in self-stigma. They engage in a lot of self-blame and hold themselves responsible for the outcomes, even though they weren't aware of the effects of exposure. I've interacted with a lot of birth parents who said that they didn't know. They simply didn't know that drinking during pregnancy would have all of these impacts. They heard from their OBGYN that they could have one glass of wine, it was safe, so they were given misinformation. Or some of them were, they had dependence issues, so they could not get rid of that during that time. They tried to get some treatment. Some of them couldn't even get treatment. They wanted to get treatment. Maybe their partner held them back and said, no, you really don't need that. It's fine. Your situation is not that bad. So the only time that they get treatment was maybe after their child was born, because their child was taken away afterwards. So a lot of these mothers, they thought that either it wasn't going to hurt, or they couldn't get treatment, or they couldn't get past their dependence or abuse, substance abuse issues. But when they look back, all of them do regret it. So we should not have that stereotype or that thought that they did this at all willingly to their children. They regret it. And then here is the worst part that, again, that breaks my heart a lot. The self-stigma that they have. Once they have a child with FASD and that child is diagnosed, they don't consider, the birth mothers don't consider any of the factors that led to their drinking. Maybe they had an abusive history. They had an abusive partner. They were experiencing domestic violence. They were living in poverty, a low SES. They didn't have access to prenatal care. They didn't have access to medical care, health insurance, and all of these factors. They were marginalized. Maybe they're from a marginalized group, ethnically and racially and religiously. So immigrants, so many different reasons. But what do? They put all of those aside, and all they can focus on is that I did it to my child. I'm the one to blame. This is not a great way to start out with. This is not a good way that they should be living. And this is not a good way to continue their life in a meaningful way while they're trying to get better, right? So what does then that self-blame do? What is the consequences of that self-stigma? Self-stigma impedes or interrupts the parent-child relationship. That's not something we need in our children with FASD. Our children with FASD need a great attachment, very strong bond. For those of you who are foster parents out there, you would appreciate that the bond that you built with your child is the most valuable asset that you have. Children with FASD need a good bond. We don't need the mothers keeping to blame themselves for what has happened. We are not minimizing the impact of it, but we really shouldn't be focusing solely on that part, because that's not going to help them move forward, okay? So it also prevents them from seeking support. The more they blame themselves, the more they get into depression, the more they drink, or the less they will ask for help because they are ashamed, they're embarrassed, they don't want to ask for help. We don't want to put them in a position like this. We want them to seek help, to get better, to get clean, and then to be able to manage their drinking behaviors so they can be the best parents that they can be to their children who need them, right? They also will inaccurately record or report their drinking patterns. When the doctor asks them if they drank or not, maybe in that example that one of our audience has given, the mother, the biological mother, will shield or will not give that information because they're so scared of all of this stigma, okay? And how does self-stigma impact our individuals with FASD who are living it? Well, the more they believe that they cannot do anything, they will underestimate their potential. Now it's like that self-fulfilling prophecy. Now they'll start having lower self-esteem. They will underestimate their potential. They will think that there is nothing that they can do positive in this life, that they have nothing to contribute to the society. Again, this is the worst thing for a child to have or a teen to have, not having a positive outlook to the future. It will only lead to more drinking. It will only lead to depression, anxiety. It will only lead them to drop out of school and engage in the legal system and other things. So as you can see now, like with this all, the public stigma leading to self-stigma, and all of the other pieces kind of like all go hand in hand, and then we do not have definitely good outcomes. So the stigma by association, I kind of like, mentioned a little bit, but a couple of the things that I wanted to mention is this is a psychological and a social reactions to being associated with a stigmatized person. The biological mom will have the double burden, which is I drank during pregnancy and I have a child with FASD. So they're being blamed 2 times. by stigma by association. They have already the public stigma because they drank, and they also have stigma by association because they have a child with FASD. And then the non-biological parents, they experience this, as I mentioned, because they feel like they have to avoid the blame, they have to disclose that their child is adopted. They find themselves that way. And then the consequences is that lack of support. They don't want to get support because they don't want people to know that they have a child with FASD. And then therefore, the parents will feel stressed, they feel desperate, and they feel anxious. And what that leads to is social isolation, which is the worst thing that a parent who needs help, they should not be in that kind of a situation. Okay? And then the last piece I'd like to talk about is the structural stigma before our break. So structural stigma is the stigma that's reflected, legitimized, and perpetuated by institutions and by the system. Okay? So what we know about structural stigma is that, first of all, we have punitive or coercive measures. In some states, the parents, we remove the parental rights when that information is, public. Again, this is not in every state, but in some states, that's the case. And then there is also criminalization of women. But what research indicates is that both for alcohol and drugs, if we criminalize women, okay, that is detrimental to reduce stigma. It doesn't help. It definitely doesn't help to reduce stigma, to criminalize women who have substance use, difficulties, both in the area of drugs and exposure, alcohol exposure. It's the same statistic for NAS. Criminalization of drug use during pregnancy, if we take the children away and then they go to jail, this process is not going to help to reduce. What research shows is that it actually increases NAS, it increases FASD diagnosis at the end. Because what happens is that they are separated from their children from the get-go, and then they end up in jail. In jail, they don't usually get the good information that they need. They might not get the treatment. When they get out, they reoffend, and then they engage in the same issues, and then they end up in the legal system back again with maybe another child maybe on the way. So overall, it does not necessarily help. So it increases structural stigma. Another piece is that when I reviewed this part, I was a little bit baffled because I, along with our FASD steering committee, we work in the area of prevention. We do a ton of things, just like this training, to be able to disseminate this information to people out there so that, the more the better, we have better health literacy, right? So what this information indicates is that using public initiatives to promote negative judgments of alcohol use in the pregnancy and giving those abstinence or like these health messages, we need to also understand that this may not be feasible for all women. So then we have this tension between prevention and stigma. And you might say like, well, Dr. Ergun, how does this go? How does this mechanism work? We are doing good to share this information. Yes, definitely. So, however, when we share this information, just like I'm doing today or in my other trainings too, sometimes we tend to portray a very negative, blaming tone and saying like, well, if you drink, these are all the things that's going to happen to your child, so don't drink. Well, again, it's not as simple as that, but sometimes it can be perceived that way, okay? So instead of maybe putting the prevention messages as a threat, okay, we should probably focus on prevention efforts. Of course, we have to engage in prevention, but where we promote self-efficacy for all of these mothers that are out there that are really working hard to deal with their substance use difficulties. So I'll just give an example. Let's say we have a child, and then our child at home is running so much around, and we get dizzy and we want them to kind of stop running, right? So what do we usually say? We just say like, Jack, don't run, stop running, right? It's kind of like a little threat. If you run, then I'll just, take away your blah, blah, blah. So this is a kind of like a threat and kind of like that negative, putting it negatively out there to kind of like try to stop the behavior, right? Well, Jack may or may not stop running based on what he wants to do in terms of getting the video game or not. But it really doesn't tell him what to do if he doesn't know what to do instead of running, right? So instead, what we can say is that, Jack, I want you to use your walking feet, all right? When you run, you can just knock down something. So I want you to use this, walking feet. So what we're telling here is that we're giving Jack an opportunity to have a better control over their behaviors, and replacing the negative behavior with the positive behavior, okay? So this is much more better because now the child knows what to do, and they feel probably better about their behavior, that, okay, well, if I don't run, then what can I do? I can try to use my walking feet maybe in a fast way, and maybe I can try that instead of just trying to figure out then what else can I do. I don't know. It's the same in when we give these prevention messages. If we do not pair them with a positive of, well, don't do this, but you're in a situation where you have already a substance use difficulty and an issue, what can you do? Because you may not be readily stopping if that's not an option for you. For those who understand it and who can, that's a great message. But what about many, many, many mothers out there who are thinking about it, contemplating to stop, but they have such dire conditions and circumstances in their lives, a partner who is not supportive, a partner who is giving some like domestic violence, and they're in poverty, they already have 2 other children with special needs. They just need something to cope with. And I'm not saying that should be, of course, substances, but they probably feel like there is nothing else that would replace the substance that they're engaging in. So what can we give to these mothers? How can we approach them so that it's not like this carrot stick, situation where we tell them, just don't drink, then you won't have a child with FASD. What I'm saying is that it might not be as simple as that for a big portion of our population that we are engaging in with, okay? So I just wanted to kind of like put it out there that I think all of us who have really good intentions to engage in that, to stop that, structural stigma, will also have a lot of role into kind of like cutting and stopping that piece, where we also pair it with really nice, other messages where we can kind of give them some opportunities as to, if they don't drink, during pregnancy, then how can they cope with all of the things that they're experiencing with at that moment. Okay. So I think it's around 2:30, and that kind of like, and then as an answer to this question, I think we already figured that out, right? Mothers of children with FASD do experience greater stigma and stress compared to all mothers of children with mental illnesses or substance use disorders. So I'll stop here in this part of the stigma, and then I will take some questions because we have a few minutes before 2:30, and then we can take our, a little bit of a, 5-minute break or so for coffee and some, natural breaks there, and I will get some of those questions in the meantime.
Yeah, we have a question that says, this is from before you went on to the next section.
Sure.
She kind of did it at the same time that you went on. She says, can FASD cause soft spots to not form or to close in pregnancy?
We say like after they're born, I guess that's the question, like if that would cause them to not form or close. So alcohol disrupts with the ability for the, it leads to birth defects. So first, I'll just say that. And then I think if I'm understanding right, some of the parts of the brain, the neural tube in the first trimester, it needs to close. And when it closes, it becomes the brain and the spinal cord meshed kind of like together. So it kind of like starts to be the spinal cord some parts, and then the other part starts to be the brain. But the neural tube has to close. For example, in some of the neurodevelopmental disorders such as spina bifida, the neural tube doesn't close appropriately. And alcohol definitely leads to some of those instances too. And then there is one diagnosis under the FASD umbrella that's called alcohol-related neurodevelopmental birth defects. Okay, so if a child has the birth defects that are documented to be as a result of the alcohol exposure, then they can be diagnosed with RAMB, which is the alcohol-related neurobehavioral, birth defects. Okay, so it definitely can lead to some of those soft spots to not close appropriately as well.
Next question is, thus far, I have not come across many biological mothers willing to come out and say, I drank while pregnant. My kiddo has FASD. I guess that's just a statement. To encourage biological moms. This is from JJ Dunham. He said he hopes to encourage biological moms to come forward, not be afraid, and seek help raising their FASD children.
Excellent. I think that's a great initiative and an effort on the part of our audience to. That's exactly what really what I was wanting to convey, and you're already doing that. So, if all of us can engage in that, yes, we might not have a lot of encounter with the birth parents. Probably we have more encounter with the adoptive or foster parents, because up to 70% of our children with FASD do not live with their birth parents, unfortunately, and therefore they are more in the system. So I think all of our efforts should be to kind of like try to reach out or try to locate and find and invite them so that they find a safe space to talk about these issues and talk about how they can get support as they are raising their children with FASD, and then how to prevent maybe future pregnancies so that they're better informed with their decisions. Definitely, I think it's a great way to approach.
And Heather Buck asks, are there support groups for these mothers?
So there are support groups, and I think in many different states and so forth. And then in our state, there are a lot of support groups as well. And one of our FASD state members, Aubrey Page, does a lot of those and has a lot of knowledge about as being also an adoptive parent herself, and conducts a lot of those groups. I have some of those in my resources that I'll share at the very end. So if you look at the end of the slides, there is some information on some of the ongoing ones out there. But if you can also reach out to her, I think she is, I don't know if Karen or any of our members, committee members can provide also her information. I think she's a great resource to connect with some of those parent groups out there.
We'll get her information in the chat box, in the question box, Ervin. And we also are beginning to do some partnering with the Grandparents Kinship Program. So there are, we have some grandparents that are raising kids that we're trying to partner with also. The next comment is, well, it might be more of a statement. I think this is a good statement. She says, I am a biological mom, an alcoholic in sustained remission since 11/23/2016. Unknown pregnancy, drank for the first 2 trimesters. So that's more of a statement. Thanks for sharing.
Thanks for sharing and your lived experience, and I hope this is a good and a safe space to hear some of this information that other birth parents are experiencing, and then how you can all be part of this anti-stigma prevention efforts that I'll kind of like talk about towards the end of this section. So thank you for being here.
And this question is, my nephew has microcephaly,
Mhm.
and 2 to 3 spots were closed at birth. He has signs of FASD. That's more of a statement also.
Yes, microcephaly is very common, which means smaller brain volume. Again, microcephaly is not the only way to diagnose. I mentioned all of these other areas that we need to look at for FASD, the diagnosis, but microcephaly is one of them in terms of the growth impairment, the growth retardation that they experience. So smaller brain circumference is one of it. So I would say maybe worth exploring some of those, options in terms of diagnosis.
And JJ Dunham says, amazing. I am grateful you have put out there in some situations, women don't know any other coping skills other than to drink and drug. I have lived it. I don't know the answer, but I am willing to share my experience, strength, and hope with anybody who wants to hear more about the life without any other choice than to drink and drug as their own coping skill. And thanks again for sharing that experience.
That's very empowering. I'm very grateful, for all of your, questions and feedbacks, but specifically coming, from a birth mother, I think probably at some point, then I'd love to maybe do like a focus group as far as like with the birth mother. So maybe we could do it through our FASD steering committee webpage. So be on the outlook too, also for some of those opportunities where we can all get together, discuss in a safe space and share. This is all about that. You've lived that experience. I would love, for others who are in similar situations to hear from you. This is the most powerful intervention in the area of stigma. So I really appreciate those comments.
And also, I would like to add that, JJ, if you're interested in being a part of the Ohio FASD steering committee, we are looking for parents to participate, and a birth parent will be very, very, very much welcomed.
Definitely.
The email address, my email address to send you a survey to complete if you want to join, and send you some information. If you could put your email address in the question box too, JJ, that would be very helpful. Christian White says, it's great to have awareness. I've met a now pregnant biological mom who drank while pregnant with her previous children and decided to not drink this time around. She's now aware of the adverse effects.
Definitely. And I've heard this so many times from some biological moms, and then especially those, and I was very baffled by this, is that some of the mothers said that they had encountered within the legal system, they were in jail, maybe 2 to 3 times, and they have not even heard in that setting anything about prenatal alcohol or drug exposure outcomes at all. For all of those years, they have been in and out due to some of the substance use related difficulties. And I thought about, like, I'm working with some of my other students to put together some programs for justice involved settings, where when the women are in those type of settings, at least trying to give that information so they can have more informed, decisions when they're out there trying to pull their life back together. So that's extremely difficult, but I think those are all, definitely can be done and then prevented down the way. So thanks for sharing again.
And JJ, I'd like to apologize. Alexis just sent me she's the co-chair of the FASD steering committee, and she just sent me a text and she said she was the last person to join. So you are a member of our committee and we welcome you. Sorry for the mistake.
Yes, I'll be very happy to interact soon in our meetings.
Yes.
Mm-hmm.
And that's all I have, Dr. Ergen.
All right, so let me check the time. I have 2:39. How long we would like to do, Karen?
You could do 5 to 10 minutes, whichever one you choose.
Okay, so I think we could come back at 2:50 if that's kind of around 10 minutes.
Right.
Okay. All right.
Right.
So we'll all meet around 2:50 to kind of like get started and talk a little bit more about stigma and some other factors that impact FASD. Thank you.
Right.
All right, it's 2:50. I hope everyone got a chance to have a little bit of a break and got what they needed. Just wanted to check. I always do that when I'm teaching in classes too, when we come back from a break. Can everyone hear me and see me well?
I just see the slides, Dr. Ergen.
Not me. Okay, let me. How about
Okay.
now?
Yep, I see you now.
Okay, all right, that's good. I checked. All right, so if everyone can see me and hear me, I'll just continue with talking about stigma. So I talked about some of the different types of stigma and who the stigma is targeted towards. And now I wanted to talk a little bit about the consequences of stigma towards FASD. Well, as we mentioned before, first of all, biological mothers fear that societal judgment, and as a result of that, what happens is that they conceal having consumed alcohol during pregnancy because they fear that criminalization part, they fear that their children will be taken away. So maybe while working with the biological parents, it will be helpful to go over the whatever state that they are in, some of those rules, in the state, because in a lot of them, their children don't get taken right away, unlike the drug, because alcohol is legal in general. So it's not like the drug piece. So therefore, just because they drank during pregnancy, their children will not be taken away immediately. So that's usually not the case in most of the states. However, there is the possibility of children being taken away due to other circumstances, such as if there is a documented neglect, documented different types of neglect, like physical neglect or medical neglect, or different types of abuse that it's in place, the parent not being in a capacity to parent, and so forth. Again, they'll probably be related to alcohol substance, the use of it. However, not just because they drank during pregnancy. So maybe having these conversations to give them this information, but they actually need to share the information that they drank, because that's the only way that we can also provide the diagnosis. If we do not know this, we can't know that their cognitive difficulties are due to the alcohol exposure, because a lot of children also have other neurodevelopmental delays that's not due to alcohol exposure. So we need to have that information. But the worst part is that because of the consequences of stigma, they might be reluctant to seek counseling or treatment for alcohol dependence. And this is the part where it's more detrimental to themselves as women, as individuals, and then as mothers of future children that they're going to bear. Therefore, and then to have a life that's going to be meaningful to themselves. And then a life that they'll kind of like be, looking forward to. So all in all, the most importantly, the consequences to themselves, but then it also might impact their children of not getting a diagnosis, and then and so forth. So these are some of the things that I think it's helpful to keep an eye on regarding the consequences. So kind of like put this one out from an article, kind of like really making us understand that we are ethically obligated to deal with the stigma against individuals with FASD. Because if we don't, then we have the targets of the stigma. So it's kind of like a summary of what I've talked about, but individuals with FASD, parents who are foster, adoptive, or biological, they are the targets of stigma. And then they feel that self-stigma, that personal responsibility and blame towards themselves. And then they this felt and enacted stigma experienced by the child and the family as well. If the mother experiences, the child is experiencing it, and the family is going through the same thing, the spouse and the siblings as a whole unit and a system, they are going through this stigma and so forth. And in return, all of these impact the anticipated life trajectories for individuals with FASD. If the whole family is being impacted with this, then the life expectations, what they would like to do in life for themselves, for individuals with FASD, all of that kind of like goes down and decreases. So we all are ethically obligated to decrease the stigma against individuals with FASD. As you can see here in this cycle, we need to break somewhere of any of those stigma that I talked about today. Well, we talked about the general public stigma. What about the stakeholders? I thought this was a really interesting research, and it's very recent too, by Corrigan in 2019. Kind of like looked at, in general, individuals who have a practice. That can be a doctor, clinician, social worker, but healthcare, professionals' attitudes, and what were their stereotypes, prejudices, discriminations, and what were their practices towards individuals with FASD. So they did a focus group with the stakeholders, and then what they found was that, first of all, there was a lot of prejudice against individuals with FASD. There was a lot of anger, and that includes, of course, the parents. There was a lot of disapproval. At the same time, there was a lot of sympathy. So that was kind of like intertwined together for the professionals. However, together with that, there were a lot of discriminative behaviors. What were these discriminative behaviors? Well, and I'm sure a lot of the parents out there will appreciate these because they probably experienced these before. So some of these are, first of all, professionals working with individuals or the parents with FASD. They have insufficient information about FASD. They are ill prepared to help them, these families. They did not prioritize FASD. They thought about it as like, well, it's already done. Well, I don't know what else we can do about this. They are not informed about it. They are unable to screen or identify FASD. They are not equipped well to do this task. And they have inadequate treatments to help our individuals with FASD. They also were found to lack the communication skills to ask the appropriate questions about drinking during pregnancy. Okay? They felt uncomfortable to ask the required questions. They weren't found to have good listening skills. When parents actually tried to tell them something, they weren't receptive to it. Maybe they didn't have enough time, they brushed it off, and then they weren't assertive enough to put themselves out there and ask the necessary questions. So all in all, you might say, like Dr. Argan, how is this discriminatory? It is discriminatory. If you are saying that I'm going to see patient A and provide all the resources, and I know so much about this disorder, I'm going to see patient B, I don't know much about this disorder, and I won't care to learn more. That is discriminatory. That's definitely discrimination. So we can't just say that we don't know much about it. That is definitely not an excuse. That's not an excuse. It's the same as all of the things that's going on in the country regarding social justice issues, racial issues. We can't just stand by and say, well, we don't know much about it. We haven't heard about it and so forth. That's never should be an excuse, and that shouldn't be excused when it comes to working with our population with FASD either. So also there was a discrimination against children with FASD that was found. And I talked about some of these themes before, but and then there was discrimination against the biological mothers. So all in all, then they suggested there are some mechanisms as to how to decrease these discriminatory behaviors. First of all, they talked about developing anti-stigma programs. One is through education. And what that means is that through education, we can debunk some of the myths and we can replace them with facts. And that will definitely start the process. I'm not saying it will just cut down it tremendously, but it will start the process of cutting down that stigma. Another piece is contact. What contact means is that having some kind of interaction with anyone who had a lived experience with FASD. It can be the birth parent, it can be the foster adoptive parent, it can be the individual with FASD. It can be a relative of someone with FASD. It can be the teacher of the child with FASD, or a professional like myself who does assessments, or other professionals who provide treatments. So it decreases the stigma by challenging their prejudices, just like what I'm trying to do a little bit today, right? Challenging our prejudices against this group, and contact definitely decreases that. I'll just give a personal experience. I'm from Turkey. I'm Turkish. I'm also American, by immigration. So I've had a lot of my friends who I was the first person that they interacted as being Turkish. So they learned so many things about my country, about Middle East, and about Mediterranean through what I do, what I eat, what I wear, what I share. And they said that through this contact, they learned so many different things that they weren't aware before. So definitely that education and that personal contact helps to decrease some of those prejudices and discriminatory behavior. Maybe now when they interact with another Turkish person or someone from the Middle East, it might decrease some of the prejudices that they might have held, thinking that, okay, well, you're from this religion. I may be scared of you because you are put together with all the, violent acts that might have happened in the past. So contact, therefore, is extremely, extremely important and very powerful. So how can we do that? One thing is, in terms of the education, we need to definitely target the training and education within the medical school system, where we need to kind of provide the residents, the pediatricians, the nurses, as they are learning about this, putting this in their ground rounds. I've been providing a lot of ground rounds at Dayton Children's, and a lot of nurses, pediatrician residents come and learn about FASD. I think this should be an ongoing effort in a lot of the places. Another piece about the contact is that we need to share stories about lived experiences. But we have to be careful about this one, in the sense that research shows us we need to share stories about what we call on the way up stories. On the way up stories is really those individuals, just like some of our audience who has shared some experiences today, they got through it, and they got through it successfully, and they are now on the way up, and they're feeling and living their fulfilled life with a lot of experiences under their belt. We would love to hear those type of stories, but at the same time, it really is impactful to hear on the way down stories, which is hear from those who are currently struggling, who are not doing well, who need some help, but who are willing to share why they struggle, how they struggle, and how can they get help, so that it will pave the way to others who are on the way to be struggling like that. Okay, so we need to do kind of like a balance between the two as we are sharing these stories, and because not everything is a success, and we all know that. And we need to share both to showcase that this is a difficult and a long road. And it's not just like this, oh, at the end, everything went fine, and then we just clap and it's all good. It's not like that. And I'm sure not me, but then those who have had the lived experience would definitely, appreciate how long and a difficult process definitely it is. So the next thing that I'd like to talk about is the impact of stigma and the health literacy. Why do we talk about health literacy? Well, that's extremely important. So what they found is that health literacy is inversely related to stigma, meaning that there is more health literacy about a certain disorder, then there is less stigma. So they are like go in different directions. So what they found was that there was more public stigma to mothers who consume alcohol during pregnancy than biological mothers of children with FASD. So as they go through the process at this moment, there is more stigma towards them. If they are past that process, it's a little bit less. But overall, what they found was that higher FASD literacy, meaning knowing more about FASD, having that FASD awareness and knowledge, led to more endorsement of public priority. So let's say you got through all of these trainings and you learned lots of things about screening, diagnosis, treatment, stigma around FASD. You take it to your organization and you share it with others. And then an opportunity comes, a grant comes, and then you might say, let's do a prevention program with the birth mothers of FASD. This is a very prevalent thing, and our county is struggling with this. Let's spend our public dollars on this area. As opposed to another organization who doesn't have a whole lot of FASD literacy, and they will not be able to do the same thing because they don't have that knowledge, they don't have that awareness, therefore they will not have that motivation to work on the prevention efforts and so forth. So stigma and health literacy are correlated in the sense that when we increase one up, then the other one kind of nicely decreases. So therefore, again, we need to continue our ongoing efforts to educate the public and our professional world. And then in some ways, education may be more important than contact. That's what they found in the area of FASD, because of the fact that we can disseminate the information to bigger masses. For the contact, we need those wonderful birth parents and adoptive parents out there. It may not be as easy to find them, right? We are lucky to have, in our committee, but not all organizations will be that lucky to kind of like to be able to find and to have those to be willing to share these, experiences. So it is harder to find, locate, and then have them on board so that they can share these experiences. Therefore, contact becomes a little bit more difficult. Therefore, we say that we start with education, and then we put that together with contact of those who have had the lived experience. And then I think we can more successfully achieve our anti-stigma efforts. And then the last piece of research that I wanted to share was about media. I thought about, should I include this or not? But I thought, what is more powerful than media and social media? This was not social media, but I really wonder if this could be replicated in a social media platform, because now social media is everything, right? Especially for our children and teens and young people, or any of us at this point. So overall, what we know is that media plays a vital role in setting the public agenda and shaping people's attitudes about anything, right? And we all know that inaccurate information that's portrayed in the media can be really, really powerful. And so if in the media talking about alcohol consumption during pregnancy is really portrayed as something like as a threat, and as something like portraying the birth mothers as like, oh, how could they do that, and so forth, it would promote that guilt and fear of judgment. And as we have talked about it, it will lead to inaccurate reporting of alcohol consumption. So what they did in this study is that they looked at and evaluated the messages that were in the media, through newspapers, newsrooms, and they kind of like collected all that information and kind of like put an ear to say, okay, let's hear what the media is saying about FASD. Even if you Google like different newspapers and put FASD next to it, just let's see what comes up. This is kind of a study that they did, that piece. So what they found was that there was a frame of sympathy towards biological mothers and to children with FASD, but at the same time, there was a frame of blame and shame. So it didn't come just like with sympathy. It came with, yes, we sympathize with you, but you are to be blamed. So it kind of like went hand in hand together. Some of the things that they indicated was that the moms were vulnerable, birth moms were vulnerable, defenseless, they had chaotic lives. Media had more sympathy towards children than the birth mothers. And then they kind of like, the sympathy that they displayed was more, to me, is not a helpful way. So that was more like showing sympathy and say like, oh yeah, we're sorry for you, but we're not gonna do anything else other than feeling sorry. That's not a helpful way to approach. So they were more like saying they are babies, they pay for their mother's bad habits, they're fragile and weak. Portraying our children like that is not helpful at all. And that, again, more perpetuates their self-stigma. They start kind of believing that, yes, maybe we are weak, okay? So, and then kind of portraying things like tragedy. So even if when somebody in the media is writing a piece, putting it as like a tragedy as a headline, that is stigmatizing, that is discriminatory. Even at the media level, I think we need to do more education. We need to talk more about the impact of stigma and how powerful media is and how empowering it can be if it's not used in a way that's more stigmatizing, right? So there was, of course, a lot of shame, to mothers and so forth. They didn't include the social media, so I think including and seeing what's out there in the social media is definitely going to be, very, very helpful. So what are some of the clinical implications of this? What do we learn, from this research? What we learn is that media is giving conflicting information. Somewhere we could hear it's okay to drink, like in an Instagram post or just like in a news, report. It could say somewhere indicating that, oh, OB/GYNs have found that or said that it's okay to drink, one, glass of, white wine that will not hurt. And then another one that says like it damages the brain and things like that. So we are not also 100% together on this message of no level of alcohol is safe, right? We also learned that media produces shame and blame, and that's something definitely that while we're working with all the other systems, we need to work on the media because young people are listening to media and social media. They are more responsive to that than what their parents or friends are telling them at this point. What we also learned is that they treat individuals with FASD as objects or diagnosis, and definitely we cannot do that. We need to look at the person as a whole. They are individuals with hopes, expectations, life expectancies, and lots of wonderful days to live with their families. So we need to look at them as a whole. We need to have that strength-based approach and the whole person approach when we are looking at our children and their families with FASD. And then the last piece is we need to find, or media needs to find what messages would deter from drinking. It's not enough to say don't drink. I mentioned about this before, but media is so much more powerful. For those, they could do a story about a birth mother who struggled so much and they drank. And what did they learn? What did they feel that could help other mothers who are in similar situations? Again, everyone's circumstances is different, but we look up to those stories where we can actually get information, not just learn that they suffered. It's good to learn that they suffered in a way so that we can empathize or we can understand where they're coming from and learn about them. But it's also very helpful to know how they dealt with it. What did they do? What they didn't know at the time that they should know, what maybe the new mothers should know right now. Where are those treatments? Who is providing the treatment? How can they go get it? If they get it, will they be in trouble? Can we answer some of those questions in the media? Because then a lot of people, as I say, are looking at the TV and their phones and the internet for this type of information. And that's going to be a lot more powerful, hopefully not bringing them down, but just empowering them to a level that they can go and try to find that help. And the last piece is this segment that I kind of wanted to talk about. I know I kind of reviewed a lot of this piece, but just wanted to say some of the best practices and some of the myths. So the myth is FASD services apply to only few people. I think we are all good on that part, right? So far we know 2 to 5% or 4.7% of individuals are impacted by FASD. So that's a myth, right? FASD is a rare disorder. It only impacts at the very beginning of childhood. That's a myth. FASD is not a rare disorder, and it's a lifelong neurodevelopmental disorder. FASD is less important than other disorders because the damage has been done and we have nothing else to do. That's a myth. Brain is what we call plastic. Plasticity means that brain can make new connections. if we provide all the appropriate interventions with a stable, loving home where whether they're with the birth parents or with an adoptive parent, if there is stability, if there is continuity, if there are appropriate treatments, then the brain is able to make new connections. That means the individual is able to learn and circumvent some of those difficulties that they experience. And our individuals with FASD have lots of strengths. So we look at the whole person approach. Therefore, it is not less important than other disorders. It is as equally important as any other neurodevelopmental disorder that are out there that we are working and trying to help out. So overall, we need to evaluate the programs to decrease the impact of stigma, increase education to debunk all of these myths with the facts. We need to increase contact with birth mothers, with adoptive mothers, with individuals who have the lived experience with FASD. And we need to include biological mothers in the anti-stigma efforts because they have lived it. They have lived it firsthand as to what that stigma looks like. They've tried to deal with it, and who would be better than telling us how we can do it and how we can help the system and the next incoming birth parents so that they have more favorable outcomes. And we need to promote the relations between people with FASD by putting them into groups where they can support each other. Some of the efforts that Karen has mentioned about grandparents raising, other relatives or other family members raising children with FASD. So those are all some of the best practices. So I think this is also a good place before I start the next segment about some of the family factors and stresses that perpetuate FASD to get some of those questions.
I'm looking, I see that here's a hand. Let me look at the questions. I don't see any more questions in the box. Let me look at this hand and see what. If I look at the hand and I see it's Sabrina Walker, I can unmute her. I can unmute her. It looks like she's self-muted. You might have to unmute yourself, Sabrina, and we can hear you. Can you unmute yourself? I see you had your hand up. When I select your name, it says self-muted. Sabrina Walker. And he is self-muted and is muted by the organizer.
They may or may not be able to, maybe. I'm not sure. Yeah.
Sabrina, maybe you could put your question. Maybe you could put your question in the question box for me, because we're having problems unmuting you. We can give you a couple minutes to get that in there.
It takes time to type things. I've learned that while teaching this last year and a half online at the graduate level. I had to be patient with my students also, like when they type questions and so forth. It takes a little bit of time.
Right.
Different world.
And if anybody else has any questions.
I'll also do another little, not break, but just a break to get more questions after this small section. If, you know, they can put the questions in there and I can still address it from regarding the previous topic. I'm happy to do that.
Yeah, we'll come back to it. I don't see anything.
Okay.
Thank
All right,
you.
feel free to, please. Thank you. So now in this next segment, now that we are well versed about different types of stigma, who experiences stigma, what are the consequences of stigma, and then what are some of the best practices that we can start engaging in, I'd like to turn the attention to other diversity variables that impact FASD, and then one being the family factors and some of the stressors that our individuals and families with FASD experience. So our myths and facts, FASD is overrepresented within the foster care system. Is that a myth? Is that a fact? For those of you who haven't heard me or others talk about this piece, let's think about that and we'll come back to it. So in terms of the family factors and the stressors, First of all, individuals with FASD often experience that double jeopardy, meaning that they are prenatally exposed to substances, and mainly in our case for alcohol, but they also are at a greater risk for experiencing poor caregiving environments. Okay, so what does that mean? Well, first of all, due to the substance use, the environment that they are born in might not always be favorable, and therefore they are more likely to have higher ACEs. And the ACEs, I don't know, again, if you were live, I would say, who is knowledgeable about ACEs? Of course, a lot of people working in this area are. ACEs are kind of like all those traumatic experiences that our children might experience along the way in their lives. For example, having a parent who went to jail, having a parent with a mental health disorder, having a parent who uses substance use, the viewing domestic violence, having been exposed to different types of neglect or sexual or abuse in their lives, or having seen someone shot. These are all examples of ACEs. ACEs are unfavorable traumatic experiences. And when a child has one or more ACEs even, then they are at a heightened risk to experience PTSD or trauma behaviors. So how does that relate to our children with FASD? Well, research shows that our children with FASD are more likely to have higher number of ACEs than their peers. And that's kind of like a recent research that kind of shows us that piece. Women also experience stigma, as we talked about, around because they're using substances, and they often fear the loss of their child if they disclose it during pregnancy. So which impacts, of course, our ability to diagnose FASD and the services that they will actually get. So all in all, what we can say is that the family factors are really important. Good quality caregiving is really vital in the positive outcomes. When a child has a good quality environment after they're born, because remember, as I mentioned, the brain is, after they're born, their brain is already compromised. So what they need after they're born is stability and not chaos. No ACEs, no further trauma. They already had prenatal trauma. They do not need the postnatal trauma. So remember, I mentioned about primary difficulties and the secondary ones. So they don't need that secondary piece. Those are all risk factors. So with a good quality caregiving environment, that could definitely be a protective factor to reduce more of the adverse events, okay? And then one of the other protective factors is raising children in an intellectually stimulating home. But unfortunately, a lot of them also are in more environments where there is neglect, okay, and where the environment is not stimulating at all. So it doesn't help with further brain development. Remember I said about plasticity? Well, plasticity won't just happen on its own, right? Plasticity will happen when we continue to invest in children, when children get stimulation. They need to be talked to. They need to be played with. They need to have a parent who is present. They don't need all the toys and all the money and all the different things. They just need this type of contact, which can also be provided if the parents are aware and if they have their life circumstances available. These are all things that are free: talking, playing, spending time, being present, not exposing to violence and things like that, right? So all of these are going to be definitely protective factors. So the impact of the FASD diagnosis on the family. So overall, what we know is that 92% of the caregivers with FASD, right, they experience high levels of parental stress compared to the general American population. This is significant, 92%. It's like almost all of them experience significant level of parental stress, okay? Because having, after a child is diagnosed, or even trying to get your child diagnosed with FASD, poses several stresses to the family, like financial strain, trying to maybe go to another state to get a diagnosis, or trying to go to another part of the state because they have that clinic there and not in your area. They don't have the appropriate support, and the family is in conflict because Some family members understand what FASD is. Some others think that the child is just plain being naughty and defiant and bad. So they could have family conflict, right? So a lot of the children require intervention and support in their early childhood years. Early intervention is the key so that they can reach their appropriate milestones, right? However, we have limited support and services available for this population, and a lot of the parental groups are sometimes, difficult to, be connected to. But they were found to be parental support groups were found to be one of the best protective factors to enhance support and advocacy services for these families. So one of the goals of our presentation was also to kind of like highlight the invisible disability. So children with FASD, as I mentioned, present with a lot of behavioral and cognitive impairments, right? But when the disability is invisible and not visible, they experience more stigma, because then other people can say, well, you don't have the facial features, so I think the why you are engaging in these behaviors is just plain because you're defiant and you're just violent and so forth. So they don't know why the bad behaviors or the inappropriate behaviors are coming from. And as they get older, they experience more involvement with the law. We said like 70% of them do. So having documentation of the diagnosis and saying that this child has FASD and this is why they may behave this way helps them to navigate the legal system later in their lives. So just making sure that we can understand what that invisible disability means and what are some of those consequences for these children. The response to our question, to my myth, right? Children with FASD are 9 times more likely to be placed in the foster care home and are highly overrepresented in the child care setting. So that was not a myth, that was the fact, right? 70% of the children are separated from their birth mothers, and they do not live with their birth parents, and they are put in the system. And they usually change homes 3 to 5 times. This is significant. The more homes they change, the worse is the attachment between the parent and the child, or the caregiver and the child. And then the worse the attachment, then it leads to even more behavioral problems. So that's not good. So we want stability by age 6. But by age 6, we're not even diagnosing them at that point. The average rate of age of diagnosis is 9.5 to 10 almost. So this is pretty late. So also for foster and residential care settings, we have overrepresentation of FASD, okay? Because all in all, at the end, because they don't get diagnosed on time, a lot of the kids end up in residential setting. A lot of my kids that I evaluate, most of my referrals come from residential, because that's the time when people don't know what to do and they don't know how to deal with the behaviors, and then they just kind of like gave up and they're trying to contain the behaviors in a residential setting. So what we should understand is that if any of you are working in residential settings, foster care settings, you're a social worker with children's services, you are in the legal system, social justice involved youth, okay? So we should understand that in your settings, you should be really looking on the lookout for FASD, because you will probably have definitely some children who have this profile that you should be in a position to maybe refer out, get screened, get a diagnosis, and then maybe provide support for the families who kind of like going through this piece. So the reason why I'm raising this is that so we understand and say like, well, I'll probably not see any FASD kids, in my setting because it's not really relevant. No, a lot of the settings that a lot of us are working in, including the schools, will probably have high likelihood of having children who present with FASD that has not yet been diagnosed. So they also did a really nice research to see what are the stressors experienced by foster families, because we said children are overrepresented in the foster care systems, right? So they did interviews with the foster parents to see what their challenges were. And some of the themes that were included in there were the behavioral problems were too big to manage. They didn't know how to manage those. They weren't equipped well to deal with those behaviors. because there is really not a whole lot of programs to give them psychoeducation before they decide to foster a child with FASD. With one of my doctoral students, we're developing a curriculum of psychoeducational curriculum to provide all of this information to the foster parents or adoptive parents before they embark on this journey, to equip them, to inform them to make a good decision, so that they don't just give up and say, like, I'm done, I can't do this. There you go. And that's very detrimental to our children. So exhaustion, burnout from stress, difficulty adapting to this new role as a foster parent, harm to others or sexual behaviors of the children that I mentioned before, feeling ill-equipped to foster a child with FASD, and having that limited information as to how differently they should parent a child with FASD. We also, I've developed some video series, which I think they will be available hopefully sometime in the summer on the website. I've talked about how to navigate your child within the public when they have problem behaviors, how to parent a child with FASD, that I've talked more specifically about some of those strategies. They're short 15-minute videos. Hopefully they'll be helpful to get some of that information too. And after all, they all felt unappreciated by the system themselves. So they felt that the system didn't listen to them. They felt unheard. They were trying to explain things, but people just either brushed them off or just kind of like didn't pay a whole lot of attention specifically on what they were saying. So if you are in a foster care system, these are some of the ways that you can pay more attention, and then you can help to decrease some of those discriminatory behaviors and stigma within the foster care system. So what are some actionable steps for mental health providers? All in all, we should all recognize the need for services as early as possible as early intervention. We need to reduce the stigma for mothers who consume alcohol by discussing it in an open, non-judgmental dialogue where we provide a safe space. Then we can provide them better options for services and to support them really early on while minimizing the risk for longer-term impact and adverse events such as residential care. Also, given that the families of children with FASD are more likely to be experiencing stress, like that parental stress, we need to make sure that to assess their coping skills. Let's say you started to work with a family with FASD, right? What are their coping skills? What are their resources? What are their values? What are their expectations from their children or from themselves as a parent? What is the family's strength? What are their spiritual, religious values like that they can support this cause? And what are their resources? We definitely just not need to work on the child's behaviors only, as we are working with this population, targeting parents as the best resource, best advocate, and how can we support the parent so that the parent or the caregiver can support the child. That's, I think, is the most important. And in one of my trainings, I talked about evidence-based treatments, families moving forward. The biggest premise of that evidence-based and why it is evidence-based, meaning that it works, is that it takes into consideration the family as a unit. It doesn't just target behaviors in the child and say like, oh, I'll do some behavioral interventions and I'll send you home. And you parents try to do that at home too. No, that doesn't work with our population. We need to take care of the family and caregivers, and we need to assess their parenting stress, and we need to do all those things to decrease that parental stress. So how can we do our part? Don't be afraid to ask new mothers if they drank during pregnancy, again, in a safe way, and follow up even after they've disclosed yes or no. Maybe they said no, but just follow up. And then the early childhood years are crucial to development and then some of those long-term outcomes. One other thing that I found and I thought that was really interesting in terms of what are the characteristics of mothers or what are some of the circumstances of mothers who drink during pregnancy, because I could maybe see some of you working with those mothers maybe in a substance use clinic or in a OBGYN, in a integrated healthcare setting. right? Maybe you're not working with children, but you're working with women or parents, right? So I think it would be good to share some of those characteristics that research has shown. And in this is a very recent research from May et al., who does the same prevalence studies. And they have done a research in 2020. And what they found was that the characteristics of the mothers who used alcohol during pregnancy were that they also used drugs. So it was not just alcohol. And others, so these are all the risk factors that we can all hone in and try to prevent. Another one is these mothers found out that they are pregnant later on than other mothers. So then we could start to think, why is this the case? They are not paying attention to their bodies. They have something else going on. But what is it going on? Like they find out much later. Let's say the average time to find out that a woman is pregnant is, let's say, 8 weeks. Well, these mothers are finding out maybe around 12 weeks, which is already the first trimester is over. And if they drink during the first trimester, remember, it leads to facial features. So another information about mothers who drink during pregnancy is that they had less prenatal visits, the number of prenatal visits. So that's an area to target for prevention. And then another was that they had less access to prenatal care. First, they had less access, and they also had fewer prenatal visits than other mothers who did not drink during pregnancy. So this is also another area that I think we should definitely target so we can cut down and then provide them the services. Remember, we talked about, well, okay, then what can we do? Well, these are some of the things that we can definitely target. Another information about the birth mothers drinking is that they were found to be drinking before the pregnancy. So we're definitely talking about a pattern and then a substance use disorder. So really, really targeting women before they have children. If they have a substance use disorder, trying to connect them with the treatment or moving them towards wanting to get treatment through motivational interviewing practices, through counseling, in whatever way that that you are working with them is going to be helpful. And another risk factor is binge drinking, that these women engage in binge drinking and they continue that pattern in pregnancy. Remember, I said that the binge drinking pattern is one of the most harmful ways to unborn baby's brain. And therefore, if they can at least change their drinking pattern and then change it into and not do the binge drinking, at least that can kind of like maybe not has as detrimental, impact later on there as well. And then another piece is that the younger age groups in the rural settings were also found to be at risk, like below age 30. So what they found was that these mothers had less knowledge in the rural areas regarding prenatal smoking or prenatal drinking. So therefore also targeting rural areas and younger mothers. We're not talking about teenage, pregnancy as much here. We're more talking about more older in that sense, like after 20 and so forth, we see more of incidences for FASD. So we see less knowledge for young women below, age 30 regarding, drinking during pregnancy, and then more in the rural areas. So that would also be a great way to target those behaviors. All right. Wanted to see before I move on to impact of race, which is our last variable that I'd like to, race and ethnicity that I'd like to discuss for our webinar today. But I see the couple blinking, so I wanted to pause and stop for some questions.
Okay, we have comment and a question, I think. Thank you for saying that it is discrimination to not support evaluation and treatment of children with suspected or known FASD. Do you have any suggestion for communicating this information with entities to increase education as they focus only on best practices?
That's a wonderful question, and I think I'm just one person, and we are, as a committee, we are a bunch of people who are really working on trying to disseminate this to all different systems. We're working at the media level, We're working at the schools to infiltrate this information. We're working at the pediatrician level, at the hospitals, trying to present disease information. But, again, it's just, our organization, and then there are many organizations, and both local, statewide, and nationwide, working towards this goal. Again, this is not going to happen overnight, but I think the more we can reach out to lay, individuals, maybe not like, professionals or caregivers like yourselves who are already involved and motivated in this area, but for those who might say like, I don't really care, or I haven't heard about it and I don't really care, how can we make them care? So that's why I focused a little bit on that research on media and social media as well, to disseminate this information. I think that can be a powerful, venue and a platform to share. And that's why we're doing more like webinars and videos, things that younger people more respond to, like short messages. As a committee, we developed red flag cards where we have the basic symptoms to distribute to pediatricians so they can screen, so they can't say that, oh, I don't know about this. Well, you have the red flag cards. Can you use them? So, and then we developed we're finalizing a screener so that we can screen as well. So again, this is our own, initiatives and our own efforts, and everyone in different states can have these steering committees and different organizations to support this cause. I think we can, definitely make this happen. And I truly believe, I'm always a hopeful and a positive person in that sense, but I do believe that this is going to happen. Maybe not as fast, because it's been coined as a term in only 1973, though it's still recent. So we still have a long ways to go, but I'm definitely hopeful.
And that's all the questions we have so far, Dr.
Okay, thank you.
Mm-hmm.
So the last piece of my presentation, which I think will go more quickly, is a little bit touching on ACE and race and SES and ethnicity. Sometimes I do get a lot of questions, on, is there any differences if we have a child from a different racial ethnic background? What should we be paying attention to? Because that is definitely a diversity variable. Okay. So our myths and facts questions is, are there physical differences based upon biological factors in the facial features of racial and ethnically diverse children with FASD? So let's think about that. Is it a myth? Is it a fact? So let's see. So in terms of race and ethnicity factors, we already talked about the prevalence of FASD. But when it comes to different ethnicities, what we see is that it's the least prevalent in the Hispanic population and most prevalent in Native American and Alaska natives. And you probably, started thinking like, are we talking about a biological thing or a, environmental issue? Of course, it is an environmental issue, as many things are, right? So because we know races and ethnicity, these are socially constructed concepts, right? It's not biological. So the reason why we see some of these differences is that there is a high prevalence of alcohol use in the Native American Alaskan populations already. That definitely then leads to that being used more during pregnancy. So it's only through that mechanism that we see this type of a more higher prevalence within that population. Okay, there's a lot of research conducted in Canada in the kind of like the native population, again due to the high use of alcohol, in the reservations and so forth, and therefore we see more higher incidences, within those subgroups, ethnically and racially. But having said that, once alcohol is consumed, it impacts all races and ethnicities in the same way in terms of the facial features. So now you can see all of these children. I'll start with the one on the left, with the blue eyes, so that's a white child. And on the, right-hand side, then we see a Native American child. On the left corner bottom, we see a Black child. And on the bottom right, we see an Asian American child. Well, all of them have FAS, which is the more severe form of FASD, as I mentioned, with the facial features. So as you can see, if you remember from the earlier part of my presentation, the eyes have that epicanthal folds. They are smaller openings. Nasal bridge is flat. The philtrum is very smooth. And they have very thin upper lip, right? They have that underdeveloped jaw, smaller face, and then the flat mid face. So they present from different races, but yet they have the same facial features. So therefore, there is really no difference across, race and ethnicities as it comes in biologically. So there is no biological difference in that sense. Alcohol is the same way it disrupts the brain, and therefore it will interfere with the development of the facial features in the similar manner. So they are universal. So I already talked about that. This is just kind of like another one for the common facial features. But then we might say, well, in some races, there are some different facial features to begin with. So how do we deal with that, and how should doctors or approach it? Or if you have a child from if you've adopted a child from either internationally or from a diverse background, and you don't share that facial characteristics, right? Then how do you deal with that? How do you advocate for your child, right? So what research shows, and it's quite new, 2021 and 2017, they have looked at the differences in the lip philtrum area, okay, for different ethnic groups. And based on the biological makeup from each of these ethnic groups, the physical presentation of the lip and the philtrum area may look a little bit different. Okay, so I will show you some of that differences that Dr. Astley, Susan Astley in Hemingway in University of Washington, who developed the 4-digit code for the diagnosis, and then who developed the lip philtrum guide, has redeveloped this piece based on the racial differences. So now I'd like to get your attention here. Now, 2021, they developed two guidelines for 2 ethnic populations, because we know that for some races, like African American children or individuals, would naturally have more fuller lip area, right? And then that is more biological, right? So for that to be, detected and say like, well, this child has fuller lips, so they don't have the thin upper lip. Well, that's not the case. That's not how we should approach it. We should appreciate those biological differences and then still be able to evaluate around that. So therefore, the first guide is the first one on my left, the one that it says A on here, that was developed for Caucasian and all other races which have lips like more, the Caucasian, where it could be, again, there is a ton of differences, right? But more on the thinner side to begin with biologically. And then they also developed another guide, which is the one on my right, which is the B, for African Americans and all other races where lips appear more full, like African American. So therefore, now you can see some of these children who have the full, upper full lip presentation, but still they have FAS. The ones on the top, they have thinner lip, as you can see. And then the ones on the left, they could have a less fuller presentation. And then when it's an FAS presentation at the top, then as you can see, as it goes from 1 to 5, then we see that thin upper lip. So on this graph or on this table, 3 is average, as you can look through. But then the 3 on the left and then the 3 on the right are not same, right? The children on the right who have 3, which is average lip, that is more children who are African American or other races where the lip is naturally more fuller, okay? So the one on the left is 3 is still average. That's not considered a thin lip or a facial feature of FAS, but they are more thinner by nature. So as you go up, 4 and 5 are determined to be thin lip or a smooth philtrum, and they are indicative of FAS. So now if you look at the top parts, the 4 and 5 of both of the children who are from different races, you can still see that compared to their baseline level, they still have much thinner lip and then a smoother philtrum. Can you see that philtrum area in the 3? for children. And then the 4 and 5, it's smoothed out. There is no bump and there is no like this, kind of like this line. Can you see that and observe that? So that's definitely a nice guide. So this has been shared with geneticists and, you know, as a public information. So this is something now ethically, you know, that we are supposed to, or the doctors are supposed to take into consideration and not say that, oh, this child has fuller lips without kind of measuring and so forth. They still need to take into consideration race and how it's presented differently in terms of facial features. Another one is I want to talk briefly about socioeconomic disparities. Overall, what research shows us is that in terms of FASD, really, other than this part that I talked about, there is really no ethnic specifically, if we don't take into consideration of the high alcohol use in some populations, but biologically, there is no ethnic, racial, other than this filtering piece that I mentioned, or SES, there is no differences. That's what research after research shows. And what does that mean? FASD can arise in any population. Okay, it doesn't spare any specific population separately. Okay, but then where we see the differences is SES. When we see the underserved racial or ethnic minorities, okay, of course their circumstances will be that they have less access to prenatal care. They have less access to you know, health insurance, medical care, right? And then they will probably have more traumatic experiences due to the SES differences and the poverty that they live in. And those will lead to more drinking behaviors, and those will lead to more FASD, okay? Not because of who they are and so forth, but it's more because of where they are coming from. So that's more of that SES issues. But having said that, a lot of women who are not low SES, but they are middle or higher SES, also have a lot of opioid issues or alcohol dependence issues. They might have a little bit of a higher knowledge regarding the impact of alcohol, or they might have better circumstances, life circumstances, where someone else in their life, maybe a better doctor, is telling them, you know, that, well, you need to stop drinking, and they stop it because they listen to their doctor, or they have a doctor who already brings it up to their attention. Whereas a woman from a low SES might not have a doctor that gives the same message. So that's how it becomes more of a protective factor in terms of the SES. Also, economically, FASD can be a significant financial stressor to a family with FASD. One child in their lifetime, it costs $2 million to take care of a child and provide services to a child with FASD. And then the cost annually for children with FASD is $6 billion annually. And then children with FAS who are enrolled in Medicaid have an annual mean medical expense 9 times higher than children without FASD. So as we can see, also as a society, another maybe something important piece that maybe policymakers, politicians will more pay attention to, because they're always much more receptive to when it comes to money, when it comes to the economic impact, right? When it comes to funding and dollars and so forth. Maybe if they hear this message, this will help to cut down some of that institutional or organizational stigma, saying that, oh, yes, we need to pay attention now, because now they're hearing about the dollar. Not that it means that this is any way that there is more burden. All of the disorders will create some of that financial strain on the system. But of course, we need to take care of all of our children. But maybe this is a message that we can still take to different organizations or to politicians and policymakers to say that we need to pay attention. It's all about that education piece. And that's why I wanted to also share with you. In regard to, because I've been talking a lot about US, it's also prevalent in many different parts of the world, and the prevalence rates are similar. It's still that 2 to 5%. In some places, much higher than others, but the most highest probably is South Africa of FASD in terms of the prevalence reported rate due to economic factors such as poverty. I've been talking about poverty, right? poor maternal diet, and lifelong also stress with some of those racial and ethnic disparities that individuals in South Africa due to apartheid that I'm sure all of you are aware of. Just for time, I think I'll just move on to this piece because I think I've talked not enough about socioeconomic status. Involvement in the criminal justice system. I also mentioned that FASD is overrepresented in the criminal justice system. Individuals with disabilities in general were 44% more likely to be arrested by age 28 than those without disabilities. So having a disability in general or having a neurodevelopmental disability in general is a risk factor to be involved in the criminal justice system. And then if we add on to this, if our child with a disability is a Black, male, then they are particularly at a high risk arrest, or 55% arrested by age 28. So compared to the 40% of white, individuals with disabilities who have been arrested. So as you can see, race then becomes also a factor that we need to pay attention, meaning that if you are working with a Black youth, for example, or a youth from a racially and ethnically diverse background, they might also be more ending up in the criminal justice system just because of the bias and the stigma that is related to their race. So in terms of the implications for mental health providers, children of color do have the facial features, but how we measure them may be different based on their race and ethnicity, and we have to pay attention to this. We have to give this message to make the providers aware of the new research that's out there that they can use. Socioeconomic status is a social determinant of health, right? We need to take a systems approach to work with economically challenged children, knowing that they will have those ACEs, they will have more trauma, they will be bumping in the system from one place to another. Okay, and then we will more likely to encounter them in the system if we are also working in the system. African American men are overpopulated in the criminal justice system. So when working with Black individuals with FASD, it will be important to integrate social skills training, safety training, and training about sexual behaviors and so forth, and integrating those more even into their treatment, because they're already flagged in the system for being a threat. And we're working hopefully as a society to decrease that, but until we can do something more substantially about that piece, we have to be aware of the behaviors so that they can engage in those prosocial behaviors, and then also teach them ways what to do when they are approached by law enforcement to decrease the chances of they're probably going to be shot or just be harmed by the police. So in terms of our resources, I just put, some practical things that are out there. I wanted these to be take-home messages. I know I shared with you tons of information, some good research, some, food for thought that I think we all should start thinking through and discussing with our colleagues, organizations. But these are our FASD-informed best practices as we are navigating and providing, FASD-informed practices. So being aware of racial differences in the facial features, exercising caution and compassion while interviewing mothers, considering the impact of public stigma, considering the impact of organizational stigma and discriminatory practices, consider the impact of self-stigma, work on that in therapy and counseling if you're working with them. Assess the impact of the media messages. What are we hearing? How can we change that? Consider the SES differences that I talked about. Understand the overrepresentation in the legal and the child welfare system. And do not perpetuate further stigma unintentionally. I would like to underline that because I even had to working in this area so much for the last 10 years in my life and more the other 10 years that I've started this clinical work of my life. I started to think, have I ever, and I love this area and I'm so compassionate and passionate in this area, have I unintentionally done anything to perpetuate? I think we should all as clinicians and professionals should ask this question, have I given a message to even hint any kind of stigma to any child or any parent who's working and dealing with FASD? and support and provide services and treatment to mothers and children and try to make them more available. So what can each of us do? Increase awareness and FASD knowledge. You can take this knowledge and share with others out there. Understand the double jeopardy for FASD, right? And I've talked a lot about that. Breaking the cycle. If we can break the cycle in any one little piece, I think we can make an impact. And foster a safe, non-judgmental space. I think this is very, very important, especially for our birth mothers and our individuals with FASD, where they feel safe, understood, heard, and acknowledged. And then I put some resources in terms of organizations, starting with our steering committee webpage, if you do not have that already, and some information of our diagnostic center in Ohio for double ARC and some of the parent groups. And I put also some websites that you can go on and explore, and a couple of the books. There are many, many out there. So not to endorse any of these, it's just some examples. And then a little bit of more technology here. If you use your cell phone, if you put your cell phone, if you have the QR code app, if you scan that, then you will have access in your computer or in your phone immediately to all the references that I used, in this presentation. All right, I think that is the end of my presentation today, and I'm happy I can see it's blinking to get a little bit more questions as we end for today. But thank you so much for listening and being part of this very important discussion.
Okay, the question is, I get that this is such a loaded question, but does the physical effects change over the years? First question, or because of FASD interfering in development, are these lasting effects permanent?
That's a great question. And I don't know if any of you heard Dr. Chasnoff, and he is the expert on FASD, and he has done wonderful. If you can find any of his presentations or books, he talks so much about this area. The facial features do change slightly over the years, but they don't totally go away. They don't form into completely typical facial features. So they do stay, but I would recommend you to look at the video of a young girl that he has followed through the years, and you can see from childhood, the facial features are much more prominent. They are out there, and as this young woman, remarkable young woman, grew into teen and then young adult and adult, the facial features changed a little bit, and it's a little bit more difficult to identify if you don't know that she has FASD. So it changes a little bit, but all in all, what I can say is that it does not turn into typical facial features. The same things do stay, but they are not as prominent as when they were in the childhood years.
And the other question is, are there others working on similar initiatives that you are in collaboration with?
I would say I'm more, connected to all the efforts, in Ohio. But I know that at one point we wanted to do a grant and wanted to collaborate with other states. I know that there are initiatives in other states. The only thing that I think that upsets me at this point is that this is not a national, movement. We are very much working in silo, like state by state and so forth, whereas for other neurodevelopmental disorders like autism or ADHD, there are cross-state studies, research. There are so many things that are done in collaboration as more like nationally. There are some research studies that are conducted, at the national level, but I think it is much slower than for other disorders. So I'd like to see a lot more collaboration. So a lot of my initiatives, are of course through FASD Steering Committee. So if you follow some of those through their website and Facebook page as well, we post a lot of those. If you all would like to be a part of that or contribute in any way that you can, we would welcome all of you in those.
And lastly, let me look, Dr. Ergen. Lastly, Just a second. She says, lastly, how do you approach different groups of people according to their culture, economic status, religious, or gender experience? Does this initiative have them planned out?
I guess as it relates to FASD, right? Not general, but just as it relates to FASD, I would assume probably. When I am interacting with families, okay, when I'm doing my diagnostic assessment, I do what I called culturally, informed interview. Okay, we call it, ethno kind of interviewing. What that means is that I go through asking about each of the diversity variables, okay? Race, okay, well, it's not only helpful to ask about race because, you can say, what do you identify with? Okay, I identified as biracial. Okay, we don't stop there. That's just a starting point. What does that mean to you? Do you experience discrimination because you're biracial? Do you experience that within the school? Do you experience it within your community? Do you experience any community violence? Okay. Then we move on to religion. What's the role of religion in your life? Is that something that helps you out, supports you? Is that a conflict between you and your parents because you have different views of religion? Another thing is SES. What are your circumstances as a mother, as a child? If I'm gonna come out with some recommendations, do you think that you will have access to them? It doesn't make sense for me to write those in a report. I can write anything, but what are your circumstances? What are your resources? What is your past history in terms of, addictions and so forth? What do you need? What are your expectations? What does your culture tell you in terms of what is typical and normal? What is not typical and normal? I can't assume that a Black child coming from Nigeria is an immigrant and they have, FASD, is going to have the same experience as a Black child born in US. So I need to ask then questions around what has been your immigration experience? How is that contributing to the behavioral problems that you are experiencing? So it's not all about FASD. We need to make sure to have a conceptualization where we integrate all of these variables and what the family is telling us regarding all of these pieces so that they feel heard, that they feel that their cultural variables are being integrated into the diagnosis, and the recommendations and the treatment options, because not one treatment is going to look like the other one because their diversity variables are so different from one another. So this is my approach to assessment. And then I'm hoping that those who provide treatment and other services will have that kind of an approach too. And I'm happy to talk about how we integrate diversity variables in assessment or treatment in other, webinars or trainings too, because I think, as you mentioned, it's a very, very important thing that a lot of people might leave out.
And then the last thing that we have so far is just to thank you for sharing this information with us today. You are well-spoken and easy to follow. I appreciate your willingness to increase awareness, education, and reducing stigmas related to FASD.
Thank you for being here, and thank you for your positive feedback. Feel free to take all this information, the slides, what you've learned and what you'd like to convey, and then share, with others, because I think the best thing we can do is multiply this information, share with more and more. I can only share with you today. Maybe another time, maybe 3 times I can do this webinar, but that's all I can reach. But with all of you, we can reach so many more people, and then the power is all on you. Thank you for coming.
Thank you, Dr. Ergin. I know you're been working diligently on getting these trainings done, and we're going to have some modules also, everybody in the audience, on our Ohio Moss FASD page. It's a pleasure working with you this state fiscal year, and I look forward to doing the stuff next year too. I'm very
excited to continue our efforts, initiatives, and to welcome new also members from all of our trainings those who are interested to become a part of, to collaborate with us in our groups, consultation, and other ways, always feel free to. You have my email at the beginning and I think at the end as well. So please feel free to also send me a personal email to introduce yourself, to say hi, to share. I'd be happy to interact with all of you in that manner as well. Thank you.
And lastly, someone has asked, do they need to do anything else to earn their CEUs? And if Shar is still on the phone, I think all they have to do, if she's still on the webinar, I think all you have to do is fill out the evaluation that should come at the end of this session. And then she said you would get it, the certificate 7 to 10 days, working days after she receives that evaluation. Okay? Shar, is that?
Karen, I don't want to turn my phone on. My son actually just turned on the vacuum cleaner. You guys aren't going to be able to hear me, and I'm hollering at him, but he can't hear to turn it off. So I'm going to keep my mute on.
So that's what I said was true?
That is correct.
Okay, thank you. Okay. That's all we have.
All right. Bye,
And
everyone. Thanks again for joining in.
thanks, everyone.
Have a good weekend.
You
Thank
too.
you. I'm having a hard time finding where to stop the on air.
Just hit end broadcast or leave session.
The end broadcast, I could not see that for some reason.
I'll do it. Hold on.
Okay. Thank you.
Mm-hmm.